The cranial base is the most inferior part of the skull. It consists of the floor of the cranial cavity plus the inferior view of the viscerocranium minus the mandible. Together with the cranial vault, which is the part of the skull that protects the brain, it contributes to the neurocranium. Now, the cranial base is a highly irregular surface from both an external and internal view. So let's begin with the external surface of the cranial base, which is formed by the maxillary, palatine, vomer, sphenoid, and occipital bones in the midline, and the zygomatic and temporal bones laterally. In the most anterior part of the cranial base, there are the alveolar arch and the hard palate. The hard palate makes up both the roof of the mouth and the floor of the nasal cavity, and it's made up of the palatine processes of both maxillary bones and the horizontal plates of both palatine bones behind them. The maxillary teeth border the hard palate anteriorly and on both sides. Right behind the incisor teeth, there's the incisive fossa, which has one or more incisive foramina that allow the nasopalatine nerve and the sphenopalatine artery to pass through. Posteriorly and laterally, on the horizontal plate of each palatine bone, there's the greater palatine foramen, and right behind it the lesser palatine foramen, through which the greater and lesser palatine nerves and arteries emerge. Now, superior to the posterior end of the hard palate are the posterior nasal apertures, or choanae, which are also bounded by the body of the sphenoid bone superiorly, the pterygoid processes laterally, and the vomer medially. The choanae allow air to pass from the nasal cavities into the pharynx. Speaking of which, the vomer is unpaired and located in the midline. It's flat and thin and forms the nasal septum together with the ethmoid bone, to which the vomer articulates superiorly. Also superiorly, but posterior to the ethmoid, the vomer articulates with the sphenoid bone, and inferiorly it articulates with the maxillary and palatine bones. Now let's move on to the middle part of the cranial base. In this part we can see right behind the hard palate, the vomer in the midline, and the sphenoid bone laterally. The sphenoid bone is an unpaired bone that has 3 pairs of processes: the greater wings and lesser wings, which spread laterally and form the lateral aspect of the body, and a 3rd pair of pterygoid processes which possess a medial and lateral plate and extend inferiorly. Now, behind the vomer and sphenoid bones are the occipital and temporal bones. The occipital bone has 4 parts and forms the foramen magnum, which is where the spinal cord connects to the brain and also serves as a passage for the vertebral arteries, the spinal arteries, the tectorial membrane, and the spinal accessory nerves. Laterally, there are the occipital condyles, which articulate with the first cervical vertebra, or atlas, through a mobile joint that allows us to move our head forward, backward, and laterally. Now, anterior to each condyle, there's the hypoglossal canal where the hypoglossal nerve passes through. Finally, behind the foramen magnum, there's the external occipital protuberance. In the midline, there's the basilar part of the occipital bone, which has the pharyngeal tubercle, where the pharyngeal raphe and superior pharyngeal constrictor muscle attach. In regards to the temporal bone, within the petrous part there's the carotid canal, through which the internal carotid artery passes. Behind the carotid canal, there's the jugular foramen, formed by the petrous part of the temporal bone anteriorly and the occipital bone posteriorly. It is famous for allowing the passage of the cranial nerves 9, 10, and 11, and where the internal jugular vein emerges from the cranium as the continuation of the sigmoid sinus. Lateral to the jugular foramen is the styloid process and the mastoid process. Between the styloid and the mastoid processes, there's the stylomastoid foramen, through which the facial nerve and stylomastoid artery pass. Finally, anterior to the mastoid process is the external acoustic meatus, and anterior to that is the mandibular fossa, which articulates with the mandibular condyles to form the temporomandibular joint. Looking at the cranial base from the inside, it can be divided into 3 staggered depressions which lie at different levels, with the anterior fossa being the highest level and the posterior fossa being the lowest level, similar to the stairs on a staircase, the anterior, middle, and posterior cranial fossa. The anterior cranial fossa houses the frontal lobes of the brain. It's delimited by the squamous part of the frontal bone anteriorly and laterally, and the anterior margin of the lesser wings of the sphenoid posteriorly, with the ethmoid bone forming the central part of the fossa. From front to back, there's the frontal crest of the frontal bone, the crista galli, and the body of the sphenoid in the midline. Lateral to the crista galli, there's the cribriform plate of the ethmoid bone on each side where the olfactory nerves travel through, and articulating posteriorly with the lesser wings of the sphenoid bone are the orbital parts of the frontal bone, which form most of the fossa and support the frontal lobes of the brain. Now, the middle cranial fossa houses the temporal lobes of the brain. It's delimited by the posterior borders of the lesser wings of the sphenoid anteriorly, the squamous part of the temporal bone, the greater wings of the sphenoid, and the parietal bones laterally, and the dorsum sellae of the sphenoid bone and the superior borders of the petrous part of the temporal bone posteriorly. In the midline, from front to back, there's the tuberculum sellae, the hypophyseal fossa, where the pituitary gland, or the hypophysis, sits, and dorsum sellae, all coming together to collectively form the sella turcica, which looks like a horse's saddle. Laterally, on each side of the tuberculum sellae, there's the optic canal and the superior orbital fissure, delimited by the lesser and greater wings of the sphenoid and opens anteriorly into the orbit. On each side of the body of the sphenoid, there are 3 foramina that travel through the greater wing of the sphenoid bone: the foramen rotundum, foramen ovale, and foramen spinosum. Finally, right where the sphenoid, occipital, and temporal bones join, there's the foramen lacerum. All of these foramina serve as passageways and landmarks for important structures passing in and out of the cranium. Finally, the posterior cranial fossa houses the brainstem and the cerebellum. It's delimited by the dorsum sellae of the sphenoid bone and the superior borders of the petrous part of the temporal bone anteriorly, the parietal bones laterally, and the squamous part of the occipital bone posteriorly. In the midline, there's the clivus of the occipital bone, the foramen magnum, the internal occipital crest, and the internal occipital protuberance. Laterally, in the petrous part of the temporal bone, is the internal acoustic meatus, and postero-inferiorly to this is the jugular foramen, from which the sigmoid sinus travels to in the groove for the sigmoid sinus before exiting as the internal jugular vein, and medial to the jugular foramen is the hypoglossal canal. Okay. Let's take one quick break before we recap and try to identify the openings labeled on the following image. Alright, as a quick recap, the cranial base is the most inferior portion of the neurocranium and viscerocranium, excluding the mandible. In the most anterior part of the cranial base, there are the alveolar arch and the hard palate. In the middle of the cranial base, we can see the vomer in the midline and the sphenoid bone laterally. From the inside, the cranial base can be divided into 3 staggered depressions, which lie at different levels. From highest to lowest, these are the anterior, middle, and posterior cranial fossa. The anterior cranial fossa houses the frontal lobes of the brain. The middle cranial fossa houses the temporal lobes of the brain. Finally, the posterior cranial fossa houses the brainstem and the cerebellum. The ear is made up of three parts: the external, middle, and inner ear. Together, these structures help process air vibrations as sound, and this helps us enjoy our favorite music, as well as alert us of potential threats. Now, while the inner ear also plays a role in balance, the main role of the external and middle ear is to transfer and amplify sound to the inner ear with the help of the three smallest bones in the body, the auditory ossicles. Let's start with the external ear, which is by far the most common anatomical spot to hang earrings from. The external ear is actually a complex structure made of the auricle, also called the pinna, and the external acoustic meatus. Now, let's take a closer look at the auricle, which is the part of the external ear that surrounds the opening of the external acoustic meatus and funnels sound waves towards the external acoustic meatus. It is made of a regularly shaped cartilage covered with skin. The elevated outer rim of the auricle is the helix. The smaller elevated rim parallel to the helix is called the antihelix. The depression in the middle of the auricle is called the concha. Right next to the concha, there's the opening of the external acoustic meatus. Inferior to the concha, there's the lobule of the auricle. And finally, anterior to the opening, there's an elevation called the tragus. The next part of the external ear is the external acoustic meatus, which is an S-shaped canal that extends from the concha through the temporal bone to the tympanic membrane. The entire canal is covered with skin and is divided into a lateral third made of cartilage and a medial 2/3 made of bone. Now, at the end of the external acoustic meatus, there's the thin oval tympanic membrane, more commonly known as the eardrum, which separates the external ear from the middle ear. When sound waves hit the tympanic membrane, it vibrates and transfers the vibration to the three auditory ossicles of the middle ear. If you take a look through an otoscope, you will notice the tympanic membrane is concave externally, with the center of the concavity called the umbo. One of the ossicles, called the malleus, attaches to the internal surface of the tympanic membrane. The handle of the malleus extends superiorly from the umbo. At its end, there's the lateral process of the malleus, which can be seen as a small lump. Two lines extend from the lump, the posterior and the anterior malleolar folds. The thin membrane superior to these lines is called pars flaccida, as this portion is more flaccid, while the rest of the tympanic membrane is called pars tensa due to this portion of the membrane being thicker and more tense. During examination with an otoscope, the light from the otoscope reflects off the tympanic membrane and creates a cone of light that extends anteriorly and inferiorly from the umbo. Now, blood supply for the external ear and the tympanic membrane comes from direct and indirect branches of the external carotid artery. The great auricular and auriculotemporal nerves supply the majority of the skin of the auricle. The skin in front of the external acoustic meatus is innervated by the auriculotemporal nerve, while the external acoustic meatus is innervated by branches of the auriculotemporal nerve, the vagus nerve, and the facial nerve. Most of the external surface of the tympanic membrane is innervated by the auriculotemporal nerve, with some contributions from the vagus and facial nerves, while the glossopharyngeal nerve supplies the internal surface of the tympanic membrane. Finally, lymph of the external ear and the tympanic membrane drains into the superficial parotid lymph nodes, mastoid lymph nodes, deep cervical lymph nodes, and superficial cervical lymph nodes. Alright, before we move on, can you recall all of the features of the tympanic membrane on this image? Okay. Now let's switch gears and look at the middle ear, which is also known as the tympanic cavity. The middle ear is a hollow chamber found in the petrous part of the temporal bone, lined with a mucous membrane that houses the auditory ossicles. It is made of the tympanic cavity proper, which is the space immediately next to the tympanic membrane, and the epitympanic recess, which is an extension of the tympanic cavity superior to the tympanic membrane. The middle ear has 6 sides, so it is essentially shaped like a narrow box. The roof is called the tegmental wall, and it separates the middle ear from the middle cranial fossa. The floor is called the jugular wall because it separates the middle ear from the internal jugular vein. The lateral wall is called the membranous wall, and it's made up of the tympanic membrane and the lateral bony wall of the epitympanic recess. The medial wall, or the labyrinthine wall, separates the middle ear and the inner ear. Its most important features are the promontory, the oval window, and the round window. The posterior wall is called the mastoid wall, and it features a pyramidal eminence and an opening in its superior aspect called the adytus to the mastoid antrum, which connects the tympanic cavity to the mastoid air cells. Finally, the anterior wall is called the carotid wall because it separates the middle ear from the carotid canal. It also features the canal of the tensor tympani muscle superiorly and the opening of the pharyngotympanic tube that creates a connection between the tympanic cavity and the nasopharynx. The pharyngotympanic tube, also called the auditory tube, extends from the opening on the anterior wall to its opening in the nasopharynx, posterior to the inferior meatus of the nasal cavity. Its posterolateral aspect is bony, while the rest is cartilaginous, and it is lined with a mucous membrane. The pharyngotympanic tube equalizes the pressure in the middle ear with the atmospheric pressure. This is an important function, as equal pressure on both sides of the tympanic membrane allows it to move freely. Now, the cartilaginous walls of the tube are normally pressed up against the other, and the tube is closed. For the tube to work, it has to be opened, and two muscles of the soft palate help with this, namely the levator and the tensor veli palatini. The levator veli palatini muscle extends along the tube. When it contracts, it pushes on the wall of the tube, while the tensor veli palatini muscle attaches to the wall of the tube on the other side and pulls in the opposing direction. Here's a real-life example to illustrate this. Do you know when your ears get clogged on an airplane? Well, that's because the atmospheric pressure changes, and it's no longer equal to that inside the middle ear. To relieve that pesky feeling, we often swallow or chew gum. This makes the muscles of the soft palate open the pharyngotympanic tube, equalizing the pressure on both sides of the tympanic membrane and making our ears pop. Finally, let's go into some detail about the three very small but very important auditory ossicles, which are housed within the middle ear and named after the shape they resemble. The malleus, which is Latin for the hammer, is connected to the tympanic membrane on one side and the incus on the other side. The incus, or the anvil, is found in the middle of the three ossicles, attached to the innermost bone called the stapes on its medial aspect. The stapes resembles a stirrup, and its base attaches to the oval window. These tiny bones form a chain that extends from the tympanic membrane to the oval window on the labyrinthine wall and transfers vibrations from the tympanic membrane to the inner ear. Now, air vibrations made by loud sounds could easily damage the inner ear. That's why there are two muscles that dampen the movement of the auditory ossicles, the tensor tympani and the stapedius. The tensor tympani muscle, which is innervated by the mandibular nerve, extends from the pharyngotympanic tube to the malleus. It pulls on the malleus and tenses the tympanic membrane to reduce the amplitude of its oscillations. The stapedius is a small muscle inside the pyramidal eminence on the posterior wall of the middle ear. Its tendon inserts on the stapes and pulls it posteriorly, also reducing the amplitude of oscillations transmitted to the oval window and movement of the stapes. The stapedius is innervated by a branch of the facial nerve. Speaking of nerves, there are also some nerves that can be found in or traveling through the middle ear. The tympanic nerve, which is a branch of the glossopharyngeal nerve, contributes to the tympanic plexus on the promontory of the medial wall. This plexus innervates the mucous membrane that lines the middle ear and the pharyngotympanic tube. A branch of the tympanic plexus called the lesser petrosal nerve exits the middle ear to provide parasympathetic innervation to the parotid gland. Another important nerve is the chorda tympani nerve, a branch of the facial nerve. It enters the middle ear through the posterior wall, passes near the upper part of the tympanic membrane between the malleus and the incus, and exits through the anterior wall to travel towards the infratemporal fossa. Alright, as a quick recap, the external ear is made of the auricle and the external acoustic meatus. The auricle is made up by the helix, the antihelix, the concha, and the tragus. The external acoustic meatus is an S-shaped canal that extends from the concha through the temporal bone to the tympanic membrane, which separates the external ear from the middle ear. The middle ear, also known as the tympanic cavity, is a hollow chamber found in the petrous part of the temporal bone. The middle ear has 6 sides: the tegmental wall, or the roof, the jugular wall, or the floor, the membranous lateral wall, the labyrinthine medial wall, the mastoid posterior wall, and the carotid anterior wall. The pharyngotympanic tube, also called the auditory tube, extends from an opening on the anterior wall to its opening in the nasopharynx. The 3 auditory ossicles, the malleus, incus, and stapes, are also housed within the tympanic cavity. These ossicles create a chain that connects the tympanic membrane to the oval window to transfer and amplify air vibrations into the inner ear to be processed as sound. The 2 muscles that dampen the movement of the auditory ossicles are the tensor tympani and the stapedius. To be able to see everything that surrounds us, including this video, we can count on 2 very special sense organs: the eyes. The eyes can be easily injured, so each of them is protected by a hard, bony structure called the orbit. The orbits also protect the muscles, vessels, and nerves of the eyes. And between each eye and the orbit protecting it, there's a soft cushion of fat to prevent any friction or damage to the eyes. Additional protection is ensured by the lacrimal apparatus, which secretes tears to lubricate the eyes, and the eyelids, which close and open as needed. Okay, now if you look at a sagittal cut of the eyeball, you'll see it's shaped like 2 spheres fused, a bigger posterior one and a smaller anterior one, both with liquid inside. To keep this shape, the eyeball needs a solid structure, the fibrous layer, which is made of dense connective tissue and forms the skeleton of the eyeball. This layer has 2 parts, the one that makes the outer layer of the smaller sphere, called the cornea, and the one that makes the outer layer of the bigger sphere, called the sclera. The cornea is transparent and located at the anterior end of the eyeball. It allows light to pass through to the interior of the eyeball. Have you ever needed to use eye drops? Were you able to do that without instinctively closing your eyes once the drop touches your eye? The involuntary blinking is actually because of the corneal reflex. See, when something touches or irritates the cornea, it is sensed by the ophthalmic nerve, a branch of cranial nerve 5. This sensory signal then reaches the brainstem and signals the facial nerve, cranial nerve 7, to contract the orbicularis oculi to close our eyes. Now the sclera is opaque and makes the white shell of the eyes. It occupies the majority of the posterior eyeball and serves for attachment of the extrinsic muscles of the eye. Also, the sclera is pierced by the optic nerve at the posterior end of the eyeball. The place where the cornea and the sclera meet is called the corneoscleral junction. So, the bigger posterior sphere is made of another 2 layers of tissue: the vascular layer that provides blood supply, located beneath the sclera, and the internal layer called the retina, that contains the photoreceptors and supporting cells. The vascular layer, in turn, is made of 3 parts. From posterior to anterior, these are the choroid, the ciliary body, and the iris. The choroid is made of 2 layers of blood vessels that provide blood supply to both the loosely attached sclera above and the firmly attached retina beneath. The ciliary body is a thickening of the vascular layer made of blood vessels and smooth muscle, and attaches the choroid layer to the circumference of the iris. The internal surface of the ciliary body has projections called ciliary processes that serve as attachments for the suspensory ligament of the lens, which keeps the lens in place, while also secreting aqueous humor that fills the anterior chamber or smaller sphere of the eyeball. Finally, there's the iris, which is only responsible for the beautiful diversity of eye colors. Okay, that's a big fat lie. The iris is far more important than that, as it lies on the anterior surface of the lens and regulates the amount of light that passes through the pupil, a small opening in its center. Just beneath the vascular layer, there's the inner layer called the retina, where the beautiful journey of the visual pathway begins. The retina has two different parts, the optic part right below the choroid layer, where the light impacts and is sensed by the photoreceptors, and the non-visual retina, found underneath and covering the ciliary body and the posterior iris. Now, the optic part can be clinically analyzed in order to detect abnormalities that could be affecting the vision. This can be done by looking through an instrument called an ophthalmoscope at the fundus of the eyeball, formerly known as the ocular fundus, which is defined as the internal aspect of the posterior part of the eyeball where light enters and is focused. The retina of the fundus contains the optic disc, which is a circular area that corresponds to the exit of the optic nerve and the central retinal vein from the posterior eyeball, and the entrance of the central retinal artery, a branch of the ophthalmic artery which supplies the retina. This circular area contains no photoreceptors, so it's a veritable blind spot in our vision. On a funduscopic examination, you can also see the retinal arterioles and venules diverging from the optic disc, and to differentiate the two, remember that the arterioles are narrower. Another important area of the fundus is the macula of the retina, lateral to the optic disc, which contains only photoreceptor cones. This area is important because it specializes in acuity of vision, so without it, everything would be blurry. Actually, the most acute vision is sensed at the central area of the macula, called the fovea centralis, which is more depressed than the rest of the retina. Alright, now inside the eye, there are a number of transparent elements that light passes through in order to reach the retina. First, there's the cornea, then the aqueous humor, followed by the lens, and finally the vitreous humor. In contrast to the cornea, which is the structure that primarily bends light, the lens, found behind the iris, is in charge of fine-tuning our focus, just like the lens of a camera. The cornea and the lens help us delineate the two segments of the eye, which are the anterior and posterior segment. The anterior segment is between the cornea and the lens, and the posterior segment is found between the lens and the retina. The anterior segment contains the aqueous humor, which is fluid and provides nutrients for the cornea and the lens. The anterior segment is further divided into an anterior chamber between the cornea and the iris, and a posterior chamber between the iris and the lens. The aqueous humor is produced by the ciliary processes in the posterior chamber, and it flows through the pupil and into the anterior chamber. In the anterior chamber, the aqueous humor is reabsorbed by the scleral venous sinus, or the canal of Schlemm, at the angle where the iris meets the cornea, called the iridocorneal angle. On the other side, the posterior segment, also called the vitreous chamber, contains a more dense fluid called vitreous humor, which is also transparent, and it provides support to the lens and holds the retina in place. So, that's a lot of information to take in. Let's see if you can name the elements labeled from A to F on the following image of the layers of the eyeball. Let's take a bit of a closer look at some of the ways we are able to modify the path of light as it enters our eyes. The cornea, being the first and the most powerful refractive medium, makes the light rays converge to pass through the pupil. It does this in a constant manner, which means it always changes the direction of light at the same angle because the curvature of the cornea remains the same. On the other side, the lens is an elastic and biconvex structure, which means both its anterior and posterior surfaces are convex. This means the lens can be stretched or bulged to modify its curvature, and by doing this, it fine-tunes our ability to focus. Unfortunately, the lens can't stretch or bulge by itself, so it needs a partner, the smooth muscle within the ciliary body called the ciliary muscle. Imagine this muscle like a contractile ring, where the smaller-sized lens is placed at the center of it and is connected circumferentially to the ciliary body by the suspensory ligament of the lens. The ciliary muscle is under autonomic control in order to contract and relax quickly, which in turn causes the ciliary body to shrink or dilate, allowing our lens to change shape so we can rapidly change our vision from near to distant objects and vice versa. The absence of parasympathetic stimulation, as well as a potential inhibitory effect due to sympathetic innervation, causes the ciliary muscle to relax, increasing the diameter of the ciliary body, which tenses the suspensory ligament so as to pull the lens in each direction. This results in thinning of the lens, which allows for more distant objects to come into focus. In contrast, parasympathetic innervation causes contraction of the ciliary muscle via cranial nerve 3 or the ocular motor nerve, and this relaxes the suspensory ligament, decreasing the diameter of the ciliary ring. Overall, this diminishes the tension over the lens, which is now bulged in order to better focus on closer objects. This process is called accommodation. But the ciliary muscle isn't the only muscle inside the eyes, or so-called intrinsic eye muscle. There's also the iris. Just like the ciliary muscle, which allows us to focus on distant and closer objects, the iris allows us to see well either in a dark or light environment because it regulates the amount of light that passes through the pupil. It can do this because it's actually made of 2 rings of muscle. If you look at it from the front, you'll see the one that immediately surrounds the pupil is circularly arranged, called the sphincter pupillae. The second muscle, called the dilator pupillae, is radially arranged around the sphincter pupillae. Now, let's say you've been studying anatomy for quite a few hours now and need some air, so you decide to go out to the park to clear your mind. When you come out from the relative darkness of your home and are bombarded by the light of day, your parasympathetic system sends a signal to the sphincter pupillae to contract immediately, therefore contracting the pupil and preventing excessive light from entering your retina. This is because while studying anatomy in the relative darkness indoors, your eyes have become used to the low levels of light, so the sudden onset of excessive light coming into the retina causes discomfort. The consequent decrease in the pupil diameter is called miosis. Alright, now after hanging out for a while in the sunny park, you realize you have to go back home to continue studying. So exactly when you get inside your house again, your sympathetic system immediately sends a signal to the dilator pupillae to contract. This is because you are now used to having an abundance of light entering the retina, so in the new low-light environment, your body reacts by trying to dilate the pupil to allow more light in to focus. However, it could take up to 20 minutes for the muscle to contract and for you to be able to see clearly. The dilation of the pupil is called mydriasis. Alright, as a quick recap, the eyeball is made of 3 layers: the fibrous layer, made of the cornea and the sclera, the vascular layer, that comprises the choroid, ciliary body, and iris, with the pupil in its center, and finally the inner layer, or retina, which can be clinically analyzed through an ophthalmoscope. The refractive media of the eye include the cornea, aqueous humor, lens, and vitreous humor. These media belong either to the anterior or posterior segment of the eye. The anterior and posterior segments are separated from one another by the lens. The anterior segment is further divided by the iris into an anterior and posterior chamber. The accommodation of the lens allows us to see closer objects clearly, and the constriction or dilation of the pupil allow us to adapt to light and dark environments, respectively.
The infratemporal fossa, or IT fossa for short, is one of the most important spaces in the head, which acts as a conduit for neurovascular structures entering and exiting the cranial cavity. It contains vital structures such as the maxillary artery and mandibular nerve. The infratemporal fossa is an irregularly shaped space located deep and inferior to the zygomatic arch, deep to the ramus of the mandible, and posterior to the maxilla. More specifically, the fossa is bounded laterally by the ramus of the mandible, medially by the lateral pterygoid plate, anteriorly by the posterior surface of the maxilla, posteriorly by the tympanic plate and the temporal bone's mastoid and styloid processes, superiorly by the inferior surface of the greater wing of the sphenoid, and inferiorly by the attachment of the medial pterygoid muscle close to the angle of the mandible. Now, the important structures within the infratemporal fossa include muscles, vessels, and nerves. The muscles of the infratemporal fossa include the inferior portion of the temporalis muscle, the medial pterygoid and lateral pterygoid muscles. Lying either superficial or deep to the lateral pterygoid muscle, there's the pterygoid venous plexus and the maxillary artery. Deep to the lateral pterygoid, the otic ganglion and mandibular nerve, or cranial nerve V3, are located inferior to the foramen ovale. The mandibular nerve splits within the infratemporal fossa into branches that include the inferior alveolar, auriculotemporal, lingual, buccal, masseteric, and deep temporal nerves. Within the infratemporal fossa, we also see the chorda tympani nerve, which is actually a branch of cranial nerve 7. Now let's take a more in-depth look at the different structures within the infratemporal fossa, starting with vessels. First up, the maxillary artery. This artery branches off from the external carotid artery, posterior to the neck of the mandible. Then it courses either deep to or on the superficial surface of the lateral pterygoid muscle, until it reaches the pterygomaxillary fissure. From here onward, the maxillary artery continues as the sphenopalatine artery. Simple, right? Well, actually, this artery gives off no less than 15 branches along its course of the infratemporal fossa. Let's quickly run through 6 of the most important ones. First, the masseteric artery originates within the mass of the lateral pterygoid muscle, moves laterally, and passes through the mandibular notch to enter the deep surface of the masseter muscle, which it supplies. Second, the deep temporal artery arises between the temporalis and pericranium, then pierces the deep surface of the temporalis muscle, which it supplies. Third, the buccal artery passes anteriorly and inferiorly alongside the buccal nerve to supply the buccal fat pat, buccal oral mucosa, and the buccinator muscle. Fourth, there's the posterior superior alveolar artery, just anterior to the lateral pterygoid. This artery branches off the maxillary artery as it enters the pterygomaxillary fissure and enters the infratemporal surface of the maxilla via the alveolar foramen. It supplies the maxillary sinus and the upper premolar and molar teeth with their adjacent gingivae. Fifth, there's the middle meningeal artery, deep to the lateral pterygoid muscle. It arises medial to the neck of the mandible and then moves upwards, passing through a split in the auriculotemporal nerve. From this point, the middle meningeal artery traverses the foramen spinosum and enters the middle cranial fossa to supply the dura mater of the lateral wall and the calvaria of the neurocranium. Finally, there's the inferior alveolar artery, which begins its descent through the infratemporal fossa alongside the inferior alveolar nerve to enter the mandibular canal to supply the mandibular teeth, the mandible, mylohyoid muscle, and the skin in the chin region. The last vascular structure within the infratemporal fossa is the pterygoid venous plexus. This venous plexus is located between the temporalis and pterygoid muscles, and it surrounds the maxillary artery. This way, the tributaries of the venous plexus parallel the branches of the maxillary artery. Something to keep in mind about this plexus is its multiple routes of drainage. The plexus drains anteriorly to the facial vein through the deep facial vein, while also draining superiorly into the cavernous sinus via emissary veins. This is important to understand because infections of the infratemporal fossa can spread to the cranial cavity this way. Time for a quick break. Can you recall 6 important branches of the maxillary artery? Great! Now let's switch gears and take a closer look at the nerves in the infratemporal fossa. The main nerve of the infratemporal fossa is the mandibular nerve, which is also known as the mandibular division of the trigeminal nerve, or cranial nerve V3. The mandibular nerve arises from the trigeminal ganglion in the middle cranial fossa, and here it receives the motor root of the trigeminal nerve. Then it descends through the foramen ovale in the greater wing of the sphenoid, and into the infratemporal fossa, deep to the lateral pterygoid muscle. The mandibular nerve supplies motor innervation to the muscles that derive from the first pharyngeal arch, including the muscles of mastication. It also carries sensory innervation from the lower one-third of the face. Now, the mandibular nerve eventually splits into 6 main branches: the inferior alveolar, auriculotemporal, lingual, buccal, masseteric, and deep temporal nerves, all of which emerge through or at the borders of the lateral pterygoid muscle. Let's go through each of these branches. First, the inferior alveolar nerve travels inferiorly, deep to the lateral pterygoid muscle, to enter the mandibular foramen on the medial aspect of the mandible. Just before entering the mandibular foramen, the inferior alveolar nerve gives off a small branch that supplies the mylohyoid muscle, called nerve to mylohyoid. Once the inferior alveolar nerve enters the mandibular foramen, it travels within the mandibular canal, where it forms the inferior dental plexus, which sends branches to all mandibular teeth. A branch of the dental plexus, called the mental nerve, passes through the mental foramen to supply the skin and mucous membrane of the lower lip, chin, and the gingivae of the mandibular incisor teeth. Second, the auriculotemporal nerve branches posteriorly, deep to the lateral pterygoid, to encircle the middle meningeal artery. It then supplies sensory innervation to the temporomandibular joint as it courses between the head of the mandible and the external acoustic meatus. From this point on, it crosses the zygomatic process of the temporal bone and supplies the skin of the anterior side of the ear, or the auricle, and temporal region. The auriculotemporal nerve also carries postganglionic parasympathetic fibers from the otic ganglion to the parotid gland. Interestingly, these stimulatory parasympathetic fibers are from the glossopharyngeal nerve. The glossopharyngeal nerve sends preganglionic fibers to the otic ganglion, which is also located in the infratemporal fossa, just inferior to the foramen ovale and medial to the mandibular nerve. From the otic ganglion, the postganglionic parasympathetic fibers reach the parotid gland by hitching a ride along the fibers of the auriculotemporal nerve. Talk about cranial nerve teamwork! Okay, now third, there's the lingual nerve, which lies just anterior to the inferior alveolar nerve. It travels antero-inferiorly and then enters the mouth between the medial pterygoid muscle and the ramus of the mandible. Here, the lingual nerve carries sensory information from the anterior 2/3 of the tongue, the mouth's floor, and the lingual gingivae. Fourth, the buccal nerve emerges from the lateral pterygoid muscle. It also travels antero-inferiorly, and it pierces the buccinator muscle to eventually carry sensory innervation from the mucosa and skin of the cheek. The last 2 branches of the mandibular nerve are the masseteric and deep temporal nerves. The masseteric nerve crosses the mandibular notch posteriorly and enters the deep surface of the masseter to supply motor innervation and also a sensory branch of the temporomandibular joint. The deep temporal nerves originate above the upper border of the lateral pterygoid muscle and pierce the temporalis muscle from its deep surface to supply motor innervation. Great! Now, besides these 6 mandibular nerve branches, the infratemporal fossa is also home to the chorda tympani nerve, which is actually a branch of the facial nerve or cranial nerve 7. The chorda tympani nerve exits the skull via the petrotympanic fissure to enter the infratemporal fossa. Then, deep to the lateral pterygoid muscle, it hitches a ride with the lingual nerve to supply the tongue. In fact, this nerve has both special sensory and parasympathetic fibers. Special sensory or taste sensation of the anterior 2/3 of the tongue is relayed to the brain via the chorda tympani nerve, Additionally, the chorda tympani nerve also carries preganglionic parasympathetic fibers to the submandibular ganglion, before innervating the submandibular and sublingual salivary glands. Now, let's do a nervous breakdown of what we just learned. Can you label the main branches of the mandibular nerve seen here? All right, as a quick recap, the infratemporal fossa is bounded laterally by the ramus of the mandible, medially by the lateral pterygoid plate, anteriorly by the posterior maxillary surface, posteriorly by the tympanic plate and the temporal bone's mastoid and styloid processes, superiorly by the inferior surface of the greater wing of the sphenoid, and inferiorly by the attachment of the medial pterygoid muscle. It contains a number of important muscles, vessels, and nerves. The muscles of the infratemporal fossa include the inferior portion of the temporalis muscle and the lateral and medial pterygoid muscles. The maxillary artery is a branch of the external carotid artery, which travels superiorly on the lateral pterygoid muscle to the pterygomaxillary fissure, from where it continues as the sphenopalatine artery. Along the way, it gives off a number of branches, including the middle meningeal, inferior alveolar, masseteric, deep temporal, buccal, and posterior superior alveolar arteries. The pterygoid venous plexus anastomoses anteriorly with the facial vein through the deep facial vein, and also superiorly with the cavernous sinus via emissary veins. The mandibular nerve arises from the trigeminal ganglion in the middle cranial fossa, and once in the infratemporal fossa, it splits into 6 main branches: the inferior alveolar nerve, the auriculotemporal nerve, the lingual nerve, the buccal nerve, the masseteric nerve, and the deep temporal nerve. Finally, the infratemporal fossa is also home to the chorda tympani nerve, which is actually a branch of cranial nerve 7. How is it you can listen to your favorite song, close your eyes, dance, and not fall on your face? Well, there's a little thing called the inner ear that contains the vestibulocochlear organ, which gives you the ability to perceive sounds and maintain your balance. The inner ear is found in the petrous part of the temporal bone, between the middle ear laterally and the internal acoustic meatus medially. It is a small and important area which houses the irregularly shaped vestibulocochlear organ, which kind of looks like a snail shell attached to a few bony rings. Now, the inner ear contains the bony labyrinth and the membranous labyrinth. The bony labyrinth is connected to the middle ear by 2 windows. The oval window is found on the lateral wall of the vestibule and is covered by the base of the stapes, while the round window is found at the base of the cochlea and is covered by the secondary tympanic membrane. The bony labyrinth within the otic capsule is filled with paralymph and is made of a series of cavities, which are the vestibule, the semicircular canals, and the cochlea. Suspended within the bony labyrinth, there's the membranous labyrinth, which is basically a series of sacs and ducts filled with endolymph. The membranous labyrinth is organized into the utricle and saccule within the vestibule, the 3 semicircular ducts and their membranous ampullae, and the cochlear duct within the cochlea. Let's take a look at the structures responsible for balance, which are the semicircular canals on the one hand and the utricle and saccule on the other hand. There are 3 semicircular canals: an anterior, posterior, and lateral canal, oriented in the 3 different planes of space. Each canal contains a dilated end called the ampulla that contains an area of sensory epithelium called the ampullary crest. This is lined with tiny hair cells that pick up information about rotational movements of the head in the plane of the duct within which it is contained. The hair cells of the ampullary crest are innervated by the vestibular branch of the vestibulocochlear nerve, and the cell bodies of these neurons are found in the vestibular ganglion. Now, the utricle and the saccule both contain areas of sensory epithelium called maculae, which contain hair cells that detect information about linear acceleration. The hair cells in the utricle detect movements in the horizontal plane, while those in the saccule detect movement in the vertical plane. The macular hair cells are also innervated by the vestibular branch of the vestibulocochlear nerve. Now, that was a lot of info. For a quick break, feel free to pause the video and remember the parts of the inner ear that play a role in balance. Now let's switch gears and look at the structures responsible for hearing, starting with the cochlea. The cochlea is a bony tube that spirals on itself, resembling the shape of a snail shell, and contains 3 fluid-filled cavities called the scala vestibuli, the cochlear duct, and the scala tympani. Now, the cochlear duct is between the scala vestibuli and the scala tympani, and its roof is formed by the vestibular membrane, while the floor is formed by the basilar membrane. The organ of hearing, called the spiral organ, or the organ of Corti, is fixed to the basilar membrane and contains hair cells. The tips of these hair cells insert into the tectorial membrane, which is a gelatinous membrane that overlies the spiral organ. Now, how do these structures help us hear? Well, when you are listening to a song, sound waves travel to the tympanic membrane and cause it to vibrate. These vibrations are transferred to the auditory ossicles in the middle ear. The base of the stapes in the oval window vibrates and creates waves of hydraulic pressure in the paralymph, which move within the scala vestibuli. These waves then reach the helicotrema, which is the point where the scala vestibuli and scala tympani are connected, and then continue on in the scala tympani. They travel within the scala tympani to reach the round window, where the pressure waves are dampened by the secondary tympanic membrane. While traveling within the cochlea, the pressure waves push on the basilar membrane and cause it to move, stimulating the hair cells of the organ of Corti. This creates action potentials that are sent along the cochlear branch of the vestibulocochlear nerve, which has cell bodies in the spiral ganglion. The cochlear branch and the vestibular branch come together to form the vestibulocochlear nerve. The nerve then travels through the internal acoustic meatus, where it is accompanied by the facial nerve and the labyrinthine artery. The vestibulocochlear nerve exits the internal acoustic meatus into the posterior cranial fossa and enters the brainstem. Just a quick break before the recap. Can you name all the elements in this image? All right, as a quick recap, the inner ear is found in the petrous part of the temporal bone and is made of the bony labyrinth, which contains cavities filled with paralymph, and the membranous labyrinth, which is made of sacs and ducts suspended in the bony labyrinth. The parts of the bony labyrinth are the semicircular canals, the vestibule, and the cochlea. The membranous labyrinth is organized into the cochlear duct, the utricle and saccule, and the 3 semicircular ducts. Both the utricle and saccule contain areas of sensory epithelium called the maculae, which detect linear acceleration. Each ampulla of a semicircular duct contains an area of sensory epithelium called the ampullary crest and detects rotational movements of the head. Both of these cells are innervated by the vestibular branch of the vestibulocochlear nerve. The cochlea is a bony tube that spirals on itself, containing 3 fluid-filled cavities called the scala vestibuli, the cochlear duct, and the scala tympani. The roof of the cochlear duct is formed by the vestibular membrane, while the floor is formed by the basilar membrane. The organ of hearing, called the organ of Corti, is fixed to the basilar membrane and is covered by the tectorial membrane. The base of the stapes vibrates, causing waves in the paralymph in the scala vestibuli, which continue within the scala tympani at the helicotrema to reach the round window. Pressure waves push on the basilar membrane, causing it to move and stimulating the hair cells of the organ of Corti, which are innervated by the cochlear branch of the vestibulocochlear nerve.
We use our sense of smell for many things, like smelling cookies baking in the oven. But we also use it to help us taste, like when we take a big bite of those cookies. Our sense of smell is thanks to our nose. But actually, our nose does much more than just smell. It also provides a passage for air to reach the lungs, and also helps warm and filter that air before it gets down there. Now, let's go see what the nose knows. Now, the external nose is the part that we see protruding from the midline of our face. Generally speaking, the nose has a pyramidal-shaped structure with 2 openings called the nares, or nostrils. These openings are surrounded laterally by the alae, meaning wings, of the nose, and separated from one another medially by the nasal septum. Inside the nostrils is a nasal vestibule, which is lined by skin and small hairs that help filter dust particles from the air that passes through. The dorsum of the nose begins at the root, located between the eyebrows, and slopes downwards towards the apex, which is the tip of the nose. Okay, so our external nose has a skeleton that helps support its structure, made up of hyaline cartilage and bone. The hyaline cartilage is on the more anterior portion of the nose and provides most of its structure. In the midline, there's the cartilaginous part of the nasal septum, or septal cartilage. 2 lateral cartilages extend from either side of the dorsal aspect of the septal cartilage. Antero-inferior to these lateral cartilages are the paired alar cartilages that form the apex and part of the nares of the external nose. The alar cartilages are thin and flexible, allowing for dilation or constriction of the nares. The bony skeleton gives a base to the nose and includes the nasal part of the frontal bone, located at the root of the external nose, 2 paired nasal bones, the frontal processes of the maxillary bones, and in the midline, there's a superior and posterior-inferior bony part of the nasal septum. The superior part is formed by the perpendicular plate of the ethmoid bone, while the posterior-inferior part is formed by a small flat bone known as the vomer, with some contribution from the maxillary and palatine bones. Let's take a peek inside the nose now. As we enter the nasal cavity, we first pass through the nares into the nasal vestibule, which is lined by skin. Moving deeper past the vestibule, the nasal cavity is no longer lined with skin, but with nasal mucosa. The inferior 2/3 of the nasal mucosa is known as the respiratory area, which is lined with respiratory epithelium and is responsible for warming the air we breathe and trapping particles. The superior third of the nasal mucosa is known as the olfactory area, which is lined with olfactory epithelium and contains the olfactory receptors responsible for the sense of smell. Going even deeper, the nasal cavity opens to the nasopharynx through posterior nasal apertures called choanae. The pharynx is where our air and food passageways meet, and the nasopharynx is a part of the pharynx located posterior-inferior to our nasal cavity. Now, the nasal cavities are similar to duplex houses. They're connected in the middle, mirror one another, and have a roof, a floor, and a medial and lateral wall. Okay then, let's raise the roof. The roof of the nose is quite narrow, and is formed by parts of the ethmoid, frontal, and nasal bones. The major portion of the roof is formed by the cribriform plate of the ethmoid bone, which is a flat, horizontal, bony plate with small perforations for the fibers of the olfactory nerve to pass through. The sloping region anterior to the cribriform plate is formed by the frontal and nasal bones and a portion of the septal and alar cartilages. Posterior to the cribriform plate, the roof of the nasal cavities is a bit more irregular, and is formed by parts of the sphenoid bone, a portion of the vomer bone, and the sphenoidal process of the palatine bone. Now, the floor of the nasal cavity is wider than the roof, and consists of the hard palate, formed by the horizontal plates of the palatine bone posteriorly, and the palatine processes of the maxillary bones anteriorly. The medial wall is quite simple and consists of both the bony and cartilaginous aspects of the nasal septum. On the other hand, the lateral wall is quite irregular and consists of 6 bones. The ethmoid bone forms the majority of the upper part of the lateral wall. Below it are the bones that make up most of the flat surface of the lateral wall. From anterior to posterior, these are the frontal process of the maxilla, the lacrimal bone, the inferior concha, the perpendicular plate of the palatine bone, and the medial pterygoid plate of the sphenoid bone. The main features that extend from the lateral wall are 3 bony structures known as the nasal concha, which create a greater surface area to warm the air. The superior and middle nasal concha are extensions of the ethmoid bone, while the inferior concha are individual bones. These concha divide each nasal cavity into 4 lateral air passages. The sphenoethmoidal recess, located above and posterior to the superior concha, and the superior, middle, and inferior meatus, located below their respective concha. These 4 lateral passages open medially into a 5th air passage, called the common nasal meatus. Alright, we're a little nosy and want to know how much you can remember. So here's a little test. Feel free to pause the video and label the missing parts of the lateral and medial wall from A to F. Awesome! Now before we discuss the sinuses that surround the nose, let's take a look at where they drain in the nose by slicing through the 3 concha. Within the sphenoethmoidal recess, a small opening is located, and this is where the sphenoidal sinus drains. In the superior meatus, the openings of the posterior ethmoidal air cells, or ethmoid sinus, can be found. Now, the middle meatus is slightly different from the others. The frontonasal duct, which drains the frontal sinus, opens into the ethmoidal infundibulum. The anterior ethmoidal air cells also drain into the ethmoidal infundibulum. Now, continuing from the ethmoidal infundibulum is a groove in the shape of a half moon, known as the semilunar hiatus. Draining into the center of the semilunar hiatus is the maxillary sinus. Superior to the semilunar hiatus is the ethmoidal bulla, which is a bulge that contains the openings of the middle ethmoidal cells. Finally, within the inferior meatus is the opening of the nasolacrimal duct that drains the lacrimal fluid or tears from the lacrimal sac, which is why your nose runs when you cry. Now that we know where they drain in the nasal cavity, let's explore these sinuses, also known as the paranasal sinuses. The paranasal sinuses are lined with respiratory mucosa and are named after the bones they're located in, which are the frontal, maxillary, ethmoid, and sphenoid. There are 2 triangular-shaped frontal sinuses, which are located posterior to the root of the nose. Next is the pair of maxillary sinuses, which are the largest and fill the body of the maxillary bone. They're shaped like tilted pyramids, with their base located at the inferior part of the lateral wall of the nasal cavity, and the apex projecting towards the zygomatic bone. The floor of the maxillary sinus is superior to the oral cavity. And finally, the roof of the maxillary sinus shares the same bony structure that forms the floor of the orbit. The ethmoid sinuses, sometimes referred to as ethmoidal air cells, are smaller and are further divided into anterior, middle, and posterior ethmoidal sinuses. All of them are carved inside the ethmoidal labyrinth between the nasal cavities and the orbit. Lastly, the two sphenoidal sinuses are located inside the body of the sphenoid. The shape of these sinuses is quite variable, but you can think of them like two cubes separated by a septum. Test time! Let's see if you can identify the paranasal sinuses labeled from A to D here. Alrighty, now let's move on to the vasculature of the nose. The medial and lateral walls of the nasal cavity are supplied by 5 arteries, which are all branches from the internal and external carotid arteries. Now, we're going to explore the arterial supply of the nasal cavity like an open book, since a few arteries supply both walls. These are the sphenopalatine artery and the anterior and posterior ethmoidal arteries. The sphenopalatine artery is a branch from the maxillary artery, which is, in turn, a branch from the external carotid artery. Now, the sphenopalatine artery directly enters the nasal cavity through the sphenopalatine foramen. Here it further divides into a medial and a lateral branch to supply both the lateral wall and the septum. Next are the anterior and posterior ethmoidal arteries, which originate in the orbit from the ophthalmic artery, a branch from the internal carotid artery. The anterior and posterior ethmoidal arteries enter the nasal cavity through the cribriform plate, where they branch medially and laterally to supply both walls. The anterior ethmoidal artery also gives off a small branch to supply the dorsum of the external nose. Now these 3 arteries are all that supply the lateral wall, but the septum has 2 more arteries that supply it, the greater palatine artery and the septal branch of the superior labial artery. The greater palatine artery first enters the oral cavity posteriorly and runs along the inferior surface of the hard palate. Then it passes through the incisive canal anteriorly and enters the naval cavity to supply the septum. The superior labial artery is a branch from the facial artery, which is another branch from the external carotid artery. This artery first surrounds the lip, then gives off the septal branch to supply the septum. Now all 5 arteries that supply the septum anastomose anteriorly, forming a vascular network called Kieselbach's area. And this is actually where most nosebleeds originate from. The arterial blood supply of the external nose is supplied by the external nasal branches from the anterior ethmoidal arteries, septal branches from the superior labial arteries, nasal branches from the infraorbital arteries, and lateral nasal branches from the facial arteries. Now, deep to the mucosa that covers the wall of the nasal cavities, there's a submucosal plexus of veins that has 2 important functions. It helps warm the air that will go into our lungs, and it provides a way to drain the blood supplying the nose. This plexus is formed by veins that follow the same paths of the arteries, and drains into the sphenopalatine, facial, and ophthalmic veins. The veins that follow the branches of the maxillary artery drain into the sphenopalatine vein, which drains into the pterygoid plexus of veins found in the pterygopalatine fossa. The superior labial vein follows the same path as the branches of the facial arteries and drains into the facial vein. Finally, the anterior and posterior ethmoidal veins follow the branches of the ophthalmic artery and drain into the ophthalmic vein, which then drains into the cavernous sinus. The vascular supply of the external nose drains into the dorsal and lateral nasal veins, which join with the angular vein to eventually become the facial vein, which drains into the internal jugular vein. The facial vein anastomoses anteriorly via the deep facial vein with the pterygoid plexus. This plexus also anastomoses superiorly with the cavernous sinus in the cranial cavity via emissary veins. Because of these anastomoses, we have an area of the face known as the danger area, which lies within a triangle extending from the root of the nose to the corners of the mouth. It's called this because an infection entering the facial vein may potentially spread into the cranial cavity via the cavernous sinus. Last but not least, let's look at the innervation of the nose. Now, the nose is best known to convey special sensory information that allows us to smell via the olfactory nerve, or cranial nerve 1. This nerve is actually made of several small nerve fascicles, which arise from cells in the olfactory epithelium in the roof of the nasal cavity. These nerve fascicles bundle together and exit the nasal cavity through small perforations in the cribriform plate of the ethmoid bone in order to synapse in the olfactory bulb inside the cranial cavity. This information is sent back to the brain along the olfactory tract. The epithelium covering the nasal cavity also conveys general sensory innervation, such as touch or pain. This information is carried by branches of the trigeminal nerve, or cranial nerve 5, which are the ophthalmic nerve, or cranial nerve V1, and the maxillary nerve, or cranial nerve V2. These branches innervate the respiratory region and vestibule of the nasal cavity, as well as the paranasal sinuses and parts of the external nose. The ophthalmic nerve gives off a branch called the nasociliary nerve, which further branches into the anterior and posterior ethmoidal nerves. The anterior ethmoidal nerve follows the pathways of the anterior ethmoidal artery to innervate the anterior superior part of the medial and lateral walls of the nasal cavity. It terminates as the external nasal nerve, which supplies the skin around the nares, the nasal vestibule, and the apex of the external nose. The posterior ethmoidal nerve mostly innervates the ethmoidal cells and the sphenoidal sinus. The nasociliary nerve also gives off the infratrochlear nerve, which innervates the root and dorsum of the external nose. On the other hand, the maxillary nerve branches into the nasopalatine nerve, which enters the nasal cavity through the sphenopalatine foramen and runs medially to innervate the nasal septum. The maxillary nerve also supplies the posterior-inferior part of the lateral wall via two main branches. First is the greater palatine nerve, which has branches that enter through small foramina within the lateral wall to supply its overlying mucosa. The maxillary nerve also gives off the posterior superior lateral nasal branch, which also enters through the sphenopalatine foramen and helps innervate a small part of the lateral wall. Finally, the maxillary nerve gives rise to the infraorbital nerve that innervates the lateral part of the external nose and the alae. Now, the paranasal sinuses also receive innervation. The frontal sinuses are innervated by the ophthalmic nerve through branches of the supraorbital nerve. The maxillary sinuses receive innervation from the maxillary nerve through its infraorbital and superior alveolar branches. The ethmoidal sinuses are innervated by the ophthalmic nerve through the anterior and posterior ethmoidal nerves, which are branches of the nasociliary nerve, as well as the maxillary nerve through orbital branches from the pterygopalatine ganglion. And finally, the sphenoidal sinuses are innervated by a posterior ethmoidal branch from the ophthalmic nerve, as well as orbital branches from the pterygopalatine ganglion. Alright, as a quick recap, the nose is made up of the frontal, nasal, and maxillary bones, as well as the septal, lateral, and alar cartilages. The nasal cavities are separated from one another by the nasal septum, which consists of the septal cartilage anteriorly and the ethmoid bone and vomer posteriorly. Each nasal cavity is divided into the respiratory area, responsible for the passage, warming, and filtering of air, and the olfactory area, responsible for the sense of smell. The roof of the nasal cavity separates it from the cranial cavity, and it's made up of several bones, including the nasal, frontal, ethmoid, and sphenoid bones. The floor separates the nasal cavities from the oral cavity and consists of the hard palate. The medial wall consists of the nasal septum. And finally, the lateral wall has 3 bony structures called the nasal concha, which divide the nasal cavities into the inferior, middle, and superior meatus and the sphenoethmoidal recess. The meatuses communicate with the paranasal sinuses, which are 4 paired spaces filled with air that surround the nasal cavities. The paranasal sinuses are named after the bones they're located in, and they are the frontal, maxillary, ethmoid, and sphenoidal sinuses. The frontal, maxillary, and anterior ethmoid sinuses drain into the middle nasal meatus, while the posterior ethmoid sinuses drain into the superior nasal meatus, and the sphenoid sinuses drain into the sphenoethmoidal recess. The middle ethmoid sinuses drain into openings within the ethmoidal bulla. Now, the vascularization of the nasal cavities is supplied by 5 arteries, 3 of which supply both the medial and lateral walls. The sphenopalatine artery and the anterior and posterior ethmoidal arteries all have medial and lateral branches to supply the septum and the lateral wall. The septum also receives arterial blood from the greater palatine artery and the septal branch from the superior labial artery, a branch from the facial artery. The venous drainage of the nasal cavities drains into a submucosal venous plexus that drains into either the sphenopalatine, facial, or ophthalmic veins. Special sensory information for smell is carried by the olfactory nerve, or cranial nerve 1, while general sensory innervation of the nose is carried by the ophthalmic and maxillary nerves, which are branches of the trigeminal nerve, or cranial nerve 5.
When you're eating a slice of pizza, the first place food enters is the oral cavity, and it is actually where digestion starts. Here, we get to taste the pizza and form a bolus of food to swallow for further digestion in the gut. Many structures work together to chew and swallow, like the lips, teeth, and palate. So let's explore them. Now, the oral cavity itself is divided into the oral vestibule and the oral cavity proper. The vestibule is the compartment between the anterior and lateral aspects of the teeth and gingiva, and the posterior and medial aspects of the lips and the cheeks. Moving further inside is the oral cavity proper, bounded by the dental arches anteriorly and laterally, and the palate superiorly. The oral cavity proper is mainly occupied by the tongue. Now let's get back to that slice of pizza. To eat it, first you open your mouth, and the opening through which the food enters is called the oral fissure. Once the pizza's inside the oral cavity, you use the lips, which act like valves, to keep the oral fissure closed and the food inside while you're chewing. The lips, and the muscles within it, also help us exhale through the mouth, whistle, speak, or kiss. Now, the lips extend from the nasolabial sulci and the nares to the mentolabial sulcus, which is just inferior to the lips. But not all of its surface looks the same. The most remarkable feature is the part we're actually used to calling lips. A thin, hairless, reddish skin called the transitional zone, because it represents the transition between the skin of the face and the inner labial mucosa. The vermilion border is the outer edge of our lips that marks the limit between the skin of the face and the transitional zone. Finally, in the upper lip is the philtrum, which is a groove superior to the lips that extends from the middle of the vermilion border to the nasal septum. Now, the lips get their blood supply mainly from branches of the external carotid arteries. Specifically, the facial artery gives the superior and inferior labial arteries, which anastomose with one another in the midline. Innervation is provided by the trigeminal nerve, specifically through the maxillary nerve or cranial nerve V2, and the mandibular nerve or cranial nerve V3. The maxillary nerve branches into the infraorbital nerve, which gives off superior labial branches for the upper lip, the mandibular nerve branches into the mental nerve, which gives off inferior labial branches that supply the lower lip. Finally, the lip's lymphatic drainage goes to the submental lymph nodes for the medial part of the lower lip and to the submandibular lymph nodes for the upper lip and the lateral parts of the lower lip. Next up are the gingivae, or gums, which are continuous with the inner side of the lips. They're made up of connective tissue covered by mucosa, and they cover part of the teeth and the alveolar processes of the maxillary and mandibular bones. There are two types of gingiva. Immediately next to the labial mucosa is the unattached gingiva, or alveolar mucosa, which is red, shiny, and loose. And surrounding the teeth and alveolar processes is the attached gingiva, or gingiva proper, which is more pale and tightly attached to the subadjacent bone. All right, now back to that slice of pizza. Once it is inside the mouth, the next step is to take a bite and start chewing. This is where the teeth come into play. Now, besides cutting and chewing food, teeth are also important during speech, since there's certain letters or phonetic sounds that are pronounced by pressing the tongue against the teeth, like the T sound, for example. Now, we don't have only one set of teeth for all our life. We actually have two of them. The first set of 20 teeth we grow during the first years of childhood are called the primary or deciduous teeth, since they eventually fall out. And the second set of 32 teeth we have as adults are the secondary or permanent teeth. So all these teeth help us turn that delicious pizza into a bolus of food. But not all our teeth have the same features and functions. On each side of an adult set of teeth, there are 2 incisor teeth right next to the midline, which you would use to cut the pizza, 1 canine used to tear the food, and 2 premolars and 3 molars that you'd use to grind the food as you chew. Each of these teeth is made of 3 parts: the crown, the root, and the neck. The crown is the part we see when people smile. The root is nailed within the tooth socket of the alveolar processes, and the neck is a small part between the crown and the root, covered with gingivae. Now, the teeth are actually living tissue, so they need to be nourished and innervated just like any other anatomical structure. So inside each tooth, there is a pulp cavity, which houses the blood vessels and nerves, as well as connective tissue between them to fill the cavity. At the tip of the root, there's an opening through which the vessels and nerves enter or exit the pulp cavity, called the apical foramen. Now, surrounding the pulp cavity, the hard structure of the teeth is mostly made up of dentin, which is all over the crown, neck, and root. In the crown, the outer surface of the dentin is coated with enamel, which is what we actually see. And in the root, dentin is coated with cementum. Cementum also works as the surface of articulation of the teeth with the tooth sockets, which are the individual cavities found in the alveolar processes of the maxilla and mandible. Since they're basically bony structures, the tooth sockets are covered with periosteum. Now, between the periosteum of the tooth socket and the cement of each tooth, there's a tissue called the periodontium, or periodontal membrane, made mainly of collagen fibers. The periodontium works like a ligament between the articular surfaces and makes this a very particular type of joint, unique in the human body, called a dentoalveolar syndesmosis, or gomphosis, where gomphos means peg, referring to the way teeth are fastened into the tooth sockets. Okay, now both the teeth and gingiva get their arterial blood supply through branches of the maxillary arteries. The lower teeth and the corresponding gingiva facing the lips, called buccal gingiva, are supplied by inferior alveolar artery branches, directly from the maxillary artery. The upper teeth and their corresponding buccal gingiva are supplied by the posterior and anterior superior alveolar arteries. The posterior branch arises directly from the maxillary artery and supplies the molar and premolar teeth. The anterior branch originates from the infraorbital artery branch of the maxillary artery and supplies the canine and incisor teeth, Venous drainage is through the inferior alveolar vein for the lower teeth and gingiva, and the anterior and posterior superior alveolar veins for the upper teeth and gingiva. They follow the same paths as the arteries, but drain into the pterygoid plexus of veins, ultimately draining into the internal jugular vein. Some veins from the lower teeth may also drain into the facial vein. The gingiva facing the tongue, called the lingual gingiva, is supplied by branches of the lingual artery, and the one facing the palate, called the palatal gingiva, is supplied by the branches of the sphenopalatine and greater palatine arteries. Veins also follow the arteries and end up draining into the facial vein, or the pterygoid plexus. Finally, lymph from the teeth and gingiva drain into the submandibular, submental, and deep cervical lymph nodes. Now, let's look at the nerves that supply the teeth and gingiva, which are all branches of the trigeminal nerve, or CNV. The upper teeth and gingiva are innervated by branches of the maxillary nerve, or cranial nerve V2. In the pterygopalatine fossa, this nerve branches into the posterior superior alveolar nerve. Then, in the orbit, another branch of the maxillary nerve, called the infraorbital nerve, gives the middle and anterior superior alveolar nerves. These three superior alveolar nerves innervate the upper teeth and the buccal gingiva. The palatal gingiva is innervated by another two branches of the maxillary nerve, the greater palatine and the nasopalatine nerves. Now, the lower teeth and gingiva are innervated by branches of the mandibular nerve, or cranial nerve V3. In the infratemporal fossa, this nerve branches into the inferior alveolar nerve, which innervates the lower teeth. The buccal gingiva is innervated by a branch of the inferior alveolar nerve called the mental nerve, and a branch of the mandibular nerve called the buccal nerve. Finally, the lingual gingiva is innervated by the lingual nerve. All right, now before we move on, let's take a quick pause to see if you can label the types of teeth, labeled A, B, C, and D, and their different parts from 1 to 3 in the following images. Great! Now let's switch gears and look at the palate, which makes up both the roof of the mouth and the floor of the nasal cavity. It's made up of the hard and the soft palate, both lined with oral mucosa on their inferior surface. This mucosa is tightly packed with palatine glands, which secrete mucus. The hard palate, made up of bone, is the anterior 2/3 of the palate, and the posterior third is the soft palate, made of aponeurosis anteriorly and muscles posteriorly. From the posterior border of the soft palate hangs the uvula. All right now, at the posterior end of the oral cavity, there's an area called the fosses, or isthmus of the fosses, which is a passage between the oral cavity and the oropharynx. The fosses are bounded by the soft palate superiorly, the tongue inferiorly, the palatoglossal arches anteriorly, and the palatopharyngeal arches posteriorly. As their names suggest, the palatoglossal arches extend from the soft palate to the tongue, and the palatopharyngeal arches from the soft palate to the pharynx. Between them, there's a space called the tonsillar bed, where the palatine tonsils are found, which are made of lymphoid tissue, so they're part of the immune system. The main artery that supplies the tonsils is a branch of the facial artery, called the tonsillar artery. The ascending and descending palatine, lingual, and ascending pharyngeal arteries also help supply the tonsil. Let's take a closer look at the hard palate now. The bones that form the hard palate are the palatine processes of the maxillary bones anteriorly, and the horizontal plates of both palatine bones posteriorly. The maxillary teeth border the hard palate anteriorly and laterally. Posterior to the incisor teeth, there's the incisive fossa, which has one or more incisive foramina that allow the nasopalatine nerve and the sphenopalatine artery to pass through. Posteriorly and laterally on the horizontal plate of each palatine bone is the greater palatine foramen and the lesser palatine foramen, through which the greater and lesser palatine arteries and nerves pass. All right, that's a lot of information to take in, so feel free to pause the video and see if you can label the parts of the hard palate labeled from A to E. Now, the pharynx is like a crossroads for the air, which normally enters and exits through the nose, and the food that enters through the mouth. The soft palate acts like a gate that determines which path is taken, and this is possible thanks to the muscles within it. And the best part is, the names of these muscles give a bit of information about their actions or insertions. First up, we've got the tensor veli palatini, where tensor means tenses, and veli palatini refers to the soft palate, which looks like a veil. This muscle originates on the scaphoid fossa of the sphenoid bone and the cartilage of the auditory tube. The muscle runs downwards, and its tendon passes lateral to the pterygoid hamulus, and then runs medially to insert on the palatine aponeurosis. The tensor veli palatini uses the pterygoid hamulus as a pulley to tense the soft palate. This happens when we yawn and when we swallow, since a tensed soft palate allows the tongue to push against it in order to propel the bolus of food towards the oropharynx. In addition, this also opens the auditory tube. The mandibular nerve, which is a branch of the trigeminal nerve, innervates this muscle. Next up is the levator veli palatini, where levator means elevates, and veli palatini refers to the soft palate. This muscle originates on the petrous part of the temporal bone and the cartilage of the auditory tube. It runs inferiorly to insert on the palatine aponeurosis, just like the tensor veli palatini, and it elevates the soft palate when we swallow or yawn. This muscle is innervated by the pharyngeal plexus of the vagus nerve. Now, with the palatoglossus muscle, palato refers to the palate, and glossus to the tongue. So this muscle originates on the palatine aponeurosis superiorly and inserts on the side of the tongue inferiorly. Since both attachments are made of soft tissue, when it contracts, the palatoglossus brings these structures together, depressing the palate and elevating the tongue. This closes the isthmus of the fosses, which aids in the initiation of swallowing, and also allows us to breathe through the nose even when our mouths are closed. Innervation of this muscle is also by the pharyngeal plexus of the vagus nerve. Something similar happens with our next muscle, the palatopharyngeus. It originates on both the hard palate and the palatine aponeurosis, and runs postero-inferiorly to insert on the wall of the pharynx, bringing these structures together when it contracts. Therefore, the palatopharyngeus tenses the soft palate and elevates the pharynx. This muscle is also innervated by the pharyngeal plexus. The musculus uvulae originates on the posterior nasal spine of the hard palate and runs postero-inferiorly to insert on the mucosa of the uvula to shorten it when it contracts. And yet again, this muscle is innervated by the pharyngeal plexus. Finally, let's discuss the arterial supply and innervation of the palate, starting with vascularization. All the arteries that supply the palate are branches of the external carotid artery. The external carotid artery gives off two main branches to supply the palate: the maxillary and the facial arteries. In the pterygopalatine fossa, the maxillary artery gives off a branch called the descending palatine artery, which runs downward along the sphenopalatine canal and gives two branches, the greater and lesser palatine arteries. The greater palatine artery enters the oral cavity through the greater palatine foramen. Then it runs anteriorly to supply the inferior surface of the hard palate until it passes through the incisive canal to exit the oral cavity and enter the nasal cavity. The lesser palatine artery enters the oral cavity through the lesser palatine foramen. and then heads posteriorly to help supply the soft palate. Now, right after the facial artery branches from the external carotid, it gives off the ascending palatine artery, which runs superiorly on the lateral surface of the superior constrictor muscle of the pharynx. When the artery reaches the superior border of this muscle, it gives a palatine branch that turns medially and heads towards the soft palate to supply it. The veins that drain the palate follow the arteries that supply it and end up draining into the pterygoid plexus of veins, just like the veins that drain the teeth and buccal gingivae. This plexus mainly drains into the maxillary veins, which end up draining into the internal jugular vein. Finally, let's look at the innervation of the palate. The sensory innervation of the palate is through branches of the maxillary nerve, cranial nerve V2. In the pterygopalatine fossa, the maxillary nerve gives off two branches that enter the sphenopalatine ganglion. Their fibers branch directly from the ganglion to form the greater and lesser palatine nerves, which travel down the sphenopalatine canal and enter the oral cavity through the greater and lesser palatine foramina, respectively, and follow the same paths as the palatine arteries. The greater palatine nerve innervates most of the hard palate, and the lesser palatine innervates the soft palate. Now, the maxillary nerve gives off another branch in the pterygopalatine fossa called the nasopalatine nerve. This nerve enters the nasal cavity first through the sphenopalatine foramen. After innervating the septum, the nasopalatine nerve enters the oral cavity through the incisive canal and innervates the anterior part of the hard palate. Now let's take a quick quiz before the recap. Can you complete the chart with the actions and innervation of the muscles of the soft palate? All right, as a quick recap, the oral cavity is divided into the oral vestibule and the oral cavity. The lips are made up of the transitional zone, the vermilion border, and the philtrum. The lips are supplied by the superior and inferior labial arteries, branches of the facial arteries, and innervated by the superior and inferior labial nerves, branches of the maxillary and mandibular nerves, respectively. The gingivae cover part of the teeth and the alveolar processes. The teeth help cut and chew food and are made up of three parts: the crown, the root, and the neck. Inside, there's the pulp cavity, which houses the blood vessels and nerves that enter through the apical foramen to supply the tooth. The dentin forms the skeleton of the tooth and is coated with enamel in the crown and cementum in the root. Three branches of the maxillary artery supply both the lower and upper teeth: the inferior alveolar and the posterior and anterior superior alveolar arteries. The upper teeth and gingiva are innervated by branches of the maxillary nerve, and the lower teeth and gingiva by branches of the mandibular nerve. The palate makes up the roof of the mouth, with the hard palate anteriorly and the soft palate posteriorly. The hard palate is made up of the palatine processes of the maxillary bones and the horizontal plates of both palatine bones. Within each lateral boundary of the fauces is the tonsillar bed that houses the tonsils between the palatoglossal and palatopharyngeal arches. The muscles of the soft palate are the tensor and levator villi palatini, the palatoglossus, the palatopharyngeus, and the musculus uvulae. The tensor villi palatini is innervated by the mandibular nerve, and the rest are innervated by the pharyngeal plexus of the vagus nerve. The arterial supply of the palate is supplied by the greater and lesser palatine arteries for the hard and soft palate, respectively, and the ascending palatine artery, which supplies the soft palate. The sensory innervation is from the greater and lesser palatine and the nasopalatine nerve, which are branches from the maxillary nerve. The veins that drain the oral cavity drain into the pterygoid plexus, which mainly drains into the internal jugular vein.
To be able to see everything that surrounds us, including this video, we can count on a very special sense organ, the eyes. The eyes can be easily injured, so each of them is protected by a hard, bony structure called the orbit. The orbits also protect the muscles, vessels, and nerves of the eyes. And between each eye and the orbit protecting it, there's a soft cushion of fat to prevent any friction or damage to the eyes. Additional protection is ensured by the eyelids, which close and open as needed, and the lacrimal apparatus, which secretes tears to lubricate the eyes. Now, each orbit is shaped like a pyramid, so they have an apex posteromedially, or towards the inside of the skull, a base anterolaterally that opens in the facial skeleton, and 4 walls: superior, inferior, lateral, and medial. These walls are made up of several bones. The medial wall comprises the ethmoid bone in the center, the lacrimal bone and maxilla, or maxillary bone anteriorly, and the lesser wing of the sphenoid bone posteriorly. The superior wall, or roof of the orbit, is mainly formed by the orbital part of the frontal bone anteriorly and a small posterior part by the lesser wing of the sphenoid bone. The lateral wall is made up of the zygomatic bone anteriorly and the greater wing of the sphenoid bone posteriorly. Finally, the inferior wall, or floor of the orbit, is formed by the maxillary bone medially, the zygomatic bone laterally, and a tiny part by the palatine bone posteriorly. In between the 2 maxillae lies the nasal bone, but it doesn't contribute to the orbit. All right now, above the orbit there's the supraorbital margin of the frontal bone. Towards the medial part of the supraorbital margin, the supraorbital nerve and vessels pass through the supraorbital foramen, or notch. Moving on to the inside of the orbit, on the anterolateral part of the roof of the orbit, there's the lacrimal fossa, a depression in the frontal bone that houses the lacrimal gland. Now, in the apex of the orbit, there's the optic canal, in the lesser wing of the sphenoid, through which the optic nerve and the ophthalmic artery pass. Laterally, between the lesser and greater wings of the sphenoid, there's the superior orbital fissure, which allows for the passage of the superior ophthalmic vein, cranial nerves 3, 4, 6, the nasociliary nerve, and other branches of the first division of the trigeminal nerve. So that's a lot of structures. Now, if there's a superior, there's also an inferior orbital fissure, which is formed by the greater wing of the sphenoid superolaterally and the maxillary bone inferomedially. Luckily, fewer structures pass through the inferior fissure. These are the divisions of the inferior ophthalmic vein, the second division of the trigeminal nerve, called the maxillary nerve, and the infraorbital vessels. After passing through the infraorbital fissure, the maxillary nerve continues as the infraorbital nerve, and together with the infraorbital vessels, it lies on the infraorbital groove that's in the floor of the orbit. These structures then dive into the maxillary bone to come out again through the infraorbital foramen of the maxilla, below the inferior margin of the orbit. So, to easily recall the orbital openings, you can remember there's 2 of each: 2 foramina, the supraorbital and infraorbital foramina, and 2 fissures, the superior and inferior orbital fissure. Now, if we look at them from above, we can see there are 2 different axes inside the orbit, which gives us an idea of how the orbits are aligned. The medial walls of the orbits are parallel. However, the lateral walls of the orbits point laterally and are angled at 90 degrees compared to each other. Therefore, our orbital axes, which represent the anatomical alignment of the orbit, are actually angled anteriorly and laterally at a 45-degree angle to each other. This is compared to the optical axes, which is simply our line of sight or gaze, which are directly, completely straight, and are parallel to each other. Now that we've seen the bony structure of the orbit, let's take a quick break. Let's see if you can name the bones labeled from A to F and the openings from 1 to 3 on the following image. Now, besides the orbits, the eyes are also protected from irritation or injury by the eyelids. The eyelids cover the front of the eyes, preventing excessive light exposure and spreading the tears produced by the lacrimal glands all over the cornea and the exposed part of the sclera. If we take a look at a sagittal cut of the eye and the eyelids, we'll see that the eyelids are made up of layers of different tissues. From the inside out, first there's a mucus layer covering the internal part of the eyelids called the palpebral conjunctiva. This is continuous with the bulbar conjunctiva, which adheres to the periphery of the cornea and covers the exposed sclera until the corneoscleral junction. The parts where the palpebral and bulbar conjunctiva meet are called the superior and inferior conjunctival fornices, and they are located in the superior and inferior eyelids respectively. Surprisingly, the eyelids also have a skeleton. Okay, so we're not talking about bones here, but rather bands of connective tissue called the superior tarsus and inferior tarsus. These tarsi strengthen the eyelids and also hold the tarsal glands inside, which produce an oily substance that lubricates the edges of the eyelid so they do not stick together when closed, and prevents the tear film from evaporating from the surface of the eyes. The superior eyelid has an extra layer made up by the levator palpebrae superioris, which attaches to the superior tarsus and the skin of the superior eyelid, and it opens a palpebral fissure, which is the fancy way to call the space between your eyelids. The distal portion of the levator palpebrae superioris, called the superior tarsal muscle, inserts directly on the superior border of the tarsus to help open the eye completely. On the same plane as the tarsi, there's the superior and inferior orbital septa, a sheet of periosteum that extends from the periosteum of the orbit downwards to insert on the levator palpebrae superioris on the upper eyelid, and upwards to insert on the inferior tarsus itself on the lower eyelid. Moving on each eyelid, there's the palpebral part of the orbicularis oculi muscle, right before the tarsi and the orbital septa, and this muscle is in charge of gently closing the eyes. And finally, the most superficial layers of each eyelid are the subcutaneous tissue, and last but not least, the skin. On an anterior view of these structures, we can see the superior and inferior tarsi connect to the medial and lateral edges of the orbit through the medial and lateral palpebral ligaments, respectively. And in the same region, specifically where the upper eyelid meets the lower eyelid, there are the medial and lateral commissures. In addition to the eyelids, the lacrimal fluid also plays an important role in protecting the eyes, by lubricating them and also protecting them from infections. The lacrimal fluid is made from the lacrimal apparatus, which begins with the lacrimal gland, found in the lacrimal fossa of the frontal bone. The lacrimal fluid then drains through the excretory ducts of the lacrimal gland into a specialized bursa called the conjunctival sac, which is bound by palpebral conjunctiva and bulbar conjunctiva. When the eyelids close, the fluid is spread over the cornea and the sclera and directed inferiorly and medially towards the medial angle of the eye, where it accumulates in the lacrimal lake. From the lacrimal lake, the fluid drains into the lacrimal sac via the lacrimal canaliculi. The lacrimal sac is the most superior and dilated part of the nasal lacrimal duct, which goes on to carry the lacrimal fluid to the nose, specifically the inferior nasal meatus. This is why people have a runny nose when they cry. All right, but let's rewind a little bit. What makes the lacrimal gland start secreting in the first place? As you might guess, the answer to this is the autonomic nervous system. Specifically, the parasympathetic nervous system is what makes you cry. And not only because it's a bit hard to learn. The way it makes your lacrimal glands secrete lacrimal fluid goes a little bit like this. First, the presynaptic parasympathetic fibers travel with cranial nerve 7, or the facial nerve, and then with a branch of the facial nerve called the greater petrosal nerve. Then, these fibers hitch a ride with the nerve of the pterygoid canal, all the way to the pterygopalatine ganglion, which can also be referred to as the sphenopalatine ganglion where they synapse with the cell body of the postsynaptic fibers. The postsynaptic fibers are then carried by branches of cranial nerve 5. Intuitively, we're talking about the lacrimal nerve, which is a branch of the ophthalmic nerve. This goes straight to the lacrimal gland, stimulating tear production, but it also receives a small communicating branch from the zygomatic nerve, which is a branch of the maxillary nerve. On the other side, here is how the sympathetic nervous system reaches the lacrimal gland. First, the postsynaptic fibers of the sympathetic system originate in the superior cervical ganglion, from where they're carried by nerves of the internal carotid plexus, as well as the deep petrosal nerve. These nerves then join the parasympathetic fibers and together form the nerve of the pterygoid canal, and the sympathetic fibers then follow the same pathway via the lacrimal and zygomatic nerve to the lacrimal gland to cause vasoconstriction and potentially reduce tear production. Now, feel free to take a quick break and pause the video to test your knowledge on the lacrimal apparatus. Can you label these missing parts A, B, C, D, and E on the following image? Now let's look at the major nerves that pass through the orbit. There are 5 cranial nerves, or branches of them, that travel inside the orbit, and these are cranial nerves 2, or the optic nerve, the superior and inferior divisions of cranial nerve 3, or the oculomotor nerve, cranial nerve 4, or the trochlear nerve, cranial nerve 5, or the trigeminal nerve, and cranial nerve 6, or the abducens nerve. Of these, the optic nerve enters the orbit through the optic canal and then runs anteriorly and laterally towards the posterior end of the eyeball, connecting the retina to the brain. Cranial nerves 3, 4, a branch from 5, and 6 enter the orbit through its apex. Now, before they enter the orbit, the oculomotor nerve divides into a superior branch and an inferior branch, and the ophthalmic branch of the trigeminal nerve divides into 3 branches: lacrimal, frontal, and nasociliary nerves. Both branches of the oculomotor nerve, the nasociliary nerve, along with the abducens nerve, pass through the superior orbital fissure inside an area created by the common tendinous ring. The lacrimal and frontal nerves, together with the trochlear nerve, pass through the superior orbital fissure outside the common tendinous ring. Once inside the orbit, the superior branch of the oculomotor nerve goes up to innervate the superior rectus and the levator palpebrae superioris. The inferior branch runs downwards and divides into 3 branches to innervate the medial rectus, the inferior rectus, and the inferior oblique. The trochlear nerve runs medially above the levator palpebrae superioris to innervate the superior oblique. The abducens nerve runs laterally to innervate the lateral rectus. Now let's move on to the branches of the ophthalmic nerve, which is the first division of cranial nerve 5. The lacrimal nerve runs laterally to innervate the lacrimal gland. The frontal nerve runs anteriorly and divides into 2 branches, the supratrochlear and the supraorbital nerve. Finally, we have the nasociliary nerve, where naso means nose and ciliary refers to the anatomical structures in or around the eye. So this nerve gives branches called the long ciliary nerves, which bypass the ciliary ganglion and go to innervate the nasal cavity and its surroundings, and to the eye itself. Specifically, these nerves bring sympathetic information to the dilator pupillae, while also receiving sensory information from areas of the nose and eyes. Now, last but not least, an integral part of the innervation of the eye is the ciliary ganglion. Now, the presynaptic parasympathetic nerve fibers traveling within the oculomotor nerve go on and synapse on the postsynaptic neuron cell bodies within the ciliary ganglion. Additionally, the nasociliary nerve fibers carrying general sensory information and sympathetic nerve fibers also travel through the ciliary ganglion. However, these fibers don't synapse on the postsynaptic neuron cell bodies within the ciliary ganglion, but rather continue their journey through the ganglion. Then, the parasympathetic, sympathetic, and general sensory nerve fibers all exit the ciliary ganglion through the short ciliary nerves. The parasympathetic portions go on to innervate the ciliary body and the sphincter pupillae muscle. The sympathetic fibers of either the short or the long ciliary nerves innervate the dilator pupillae muscle, and the sensory fibers have a general distribution to all eye structures. Now let's look at the arteries that supply the structures inside or surrounding the orbit, which are all branches of the ophthalmic artery. Together with the optic nerve, the ophthalmic artery enters the orbit through the optic canal, right after it branches out from the internal carotid artery. These branches have pretty much the same names as the nerves: lacrimal artery, short and long posterior ciliary arteries, and so on. There's also muscular arteries that supply blood to the extrinsic eye muscles. The central artery of the retina, one of the first branches of the ophthalmic artery, pierces the optic nerve sheath and runs inside the nerve to reach and supply the retina. Venous drainage, on the other hand, is ensured by the veins that escort the arteries of the orbit. These drain either into the superior ophthalmic vein or the inferior ophthalmic vein, which then leave the orbit through the superior orbital fissure and drain into the cavernous sinus. The central vein of the retina drains, the blood from the retina into one of the ophthalmic veins or directly into the cavernous sinus. So together, these two veins drain all the structures of the eyeball itself. So, we know where all these muscles and nerves are in relation to each other because at some point, someone decided to dissect the orbit and describe what they were finding along the way. If you wanted to do the same from a superior view, you could remove the orbital part of the frontal bone or the roof of the orbit. Then you'll find, from lateral to medial, the lacrimal nerve, artery, and gland, the frontal nerve, with its branches lying above the levator palpebrae superioris, and the superior rectus muscle lying below the levator palpebrae superioris. Then the trochlear nerve innervating the superior oblique muscle. After that, you can dissect the levator palpebrae superioris, the superior rectus, and some of the intraorbital fat to get a better look of the deeper structures inside the orbit. Again, from lateral to medial, you'll see the lateral rectus with the abducens nerve innervating it, the optic nerve, which is an extension of the brain, so you'll see the dura surrounding it, then the short ciliary nerves and the long ciliary nerves around the optic nerve. And finally, you'll see the medial rectus, and you should be able to get a better look at the trochlea and the superior oblique inserting in the sclera. Okay, now, before we wrap up, let's look at two final aspects in relation to the orbit: how the eyes move within the orbit and how the extraocular muscles control the movements of our eyes. See, the gaze can't be fixed on the same point all the time. It needs to change constantly, and these eye movements need to be independent from the head. Otherwise, we'd be moving our heads all around while playing a video game. That would look a little weird. So the eyes can move along three different axes: a vertical, a transverse, and an anteroposterior axis. The movements along each axis have specific names depending on how they modify the position of the pupil. The rotation of the eyeball along the vertical axis allows the pupil to move laterally, called abduction, and medially, called adduction. When the eye rotates along the transverse axis, it allows us to look up and down, which is actually called elevation and depression of the eyeball. Now, when moving along the anteroposterior axis, the pupil doesn't actually move anywhere, but it rotates, kind of like the central logo of a car's steering wheel when you turn right or left. This allows us to keep seeing straight when we tilt our heads. When the superior pole of the eyeball moves towards the nose, it's called medial rotation. When it moves towards the temporal region, it's called lateral rotation. All right, so from the primary position of the eyeball, remember that's when you're looking straight forward. You can look in 8 different directions: up or down, right or left, and in diagonal: right and up, right and down, left and up, and left and down. Most of the extrinsic muscles of the eye, or extraocular muscles, are in charge of doing this. There's 7 of them in total, and the only one that isn't involved in the eyeball movements is the levator palpebrae superioris, which instead elevates the superior eyelid so we can open our eyes. The other 6 muscles originate around the apex of the orbit and travel forward to insert at different sites. 4 of these, the superior rectus, inferior rectus, lateral rectus, and medial rectus, originate on the common tendinous ring that surrounds the optic canal and part of the superior orbital fissure. They run forward to insert onto the sclera at the anterior half of the eyeball. The levator palpebrae superioris originates right above the superior rectus and runs forward to insert in the superior tarsus and the skin of the superior eyelid. The superior oblique originates medially to the levator palpebrae superioris and runs forward to the fibrous trochlea at the medial end of the roof of the orbit. There, the muscle passes through the trochlea, which forms a fibrous sling for the superior oblique, and drastically changes direction to run posterolaterally to insert beneath the superior rectus. The inferior oblique is the only muscle that originates anteriorly on the floor of the orbit and runs posterolaterally to insert in the lateral part of the sclera, posterior to the center of the eyeball and right beneath the lateral rectus. Now, our eyes can turn in 8 directions, but there's only 6 muscles to do that job. That means some of them have to work together to perform specific movements. Basically, to make a movement in one direction, the muscle needs to be aligned perpendicular to the axis along which the rotation occurs. That's not a problem for the lateral and medial recti, which perform abduction and adduction of the eye, respectively, because they are aligned perpendicular to the vertical axis. However, as we discussed before, the orbital axis points anterolateral, where the optical axis points straight ahead. Since the orbital and optical axes are not aligned, the rest of the muscles are somewhat oblique to all the axes of the eye. Therefore, they rotate the eyeball along the 3 axes. For example, the main function of the superior rectus, which runs anterolaterally in line with the orbital axis and inserts superiorly in the sclera, is to elevate the eyeball. And if the optical axis was in the same direction as the orbital axis, then that is the only function the superior rectus would have. However, because the optical axis is medial to the orbital axis, the superior rectus also performs adduction and medial rotation due to its oblique orientation to the optical axis. The inferior rectus also runs anterolaterally but inserts inferiorly, so it mainly depresses but also adducts and laterally rotates the eyeball. Because the superior and inferior rectus both approach the eye from the medial side, they are both adductors. The inferior oblique elevates the eyeball just like the superior rectus, but its main function is lateral rotation. The superior oblique runs posterolaterally and inserts superiorly, so it depresses the eyeball like the inferior rectus, but it mainly medially rotates the eyeball. Opposite to the 2 rectus, which adduct the eye, both obliques perform abduction of the eye. If you also noticed, both superior muscles, the rectus and oblique, medially rotate the eye, where both inferior muscles, the rectus and oblique, laterally rotate the eye. Okay, so all of this seems totally overwhelming. But in clinical practice, it's much simpler. In fact, you can evaluate the correct functioning of each muscle individually. Let's analyze, for example, the movements of the right eye. First, you ask the person to look to the right. In other words, abduction. To do this, their lateral rectus contracts. With the eye in this abducted or lateral position, the optical axis is now aligned with the orbital axis. So now, the superior and inferior recti become completely perpendicular to the transverse axis of the eye, and no longer have any secondary action in an oblique plane. Therefore, when you ask the person to look up, their superior rectus is fully responsible for elevating the eyes. And when you ask them to look down, the inferior rectus depresses the eyeball. If the person cannot elevate their eye when abducted, you know that there is dysfunction of the superior rectus because you are isolating that muscle. Then, again starting from the primary position, you ask the person to look to the left, which for them is to adduct the eyeball, which is evaluating the action of the medial rectus. Now, after adducting the eye, the oblique muscles become perpendicular to the transverse axis of the eye, so now they are in charge of solely elevating and depressing the eyes. For example, the inferior oblique, due to its attachment, will pull its posterior eye attachment downward, causing elevation of the eye. So to evaluate the inferior oblique, you ask the person to look upwards, and to evaluate the superior oblique, you ask them to look downwards. So by asking an individual to either adduct or abduct their eyes first before testing elevation and depression of the eye, we can isolate the movements of these extraocular muscles with overlapping functions to determine if there is any dysfunction. The oculomotor nerve, or cranial nerve 3, innervates all the extraocular muscles except for two. These exceptions are the superior oblique that runs through the trochlea and is innervated by the trochlear nerve, or cranial nerve 4. And finally, the lateral rectus that abducts the eye is innervated by the abducens nerve, or cranial nerve 6. All right, as a quick recap, the orbits are pyramidal-shaped cavities that house and protect the eyes, along with the eyelids and the lacrimal fluid secreted by the lacrimal apparatus. Except for the optic nerve and the ophthalmic artery, most nerves and blood vessels enter the orbit through the superior orbital fissure. The ciliary ganglion and the ophthalmic nerve provide innervation for the structures in the orbit besides the extrinsic muscles. The ophthalmic artery and veins, respectively, supply and drain blood to and from the structures inside the orbit. The eyeball can move along 3 axes, which results in 6 possible movements: abduction and adduction, elevation and depression, and medial and lateral rotation. The extrinsic eye muscles perform different combinations of these movements, and their correct function can be clinically tested. Most of them are innervated by the oculomotor nerve, except for the superior oblique, innervated by the trochlear nerve, and the lateral rectus, innervated by the abducens nerve.
The pterygopalatine fossa, sometimes called the sphenopalatine fossa, is a cavity in our skull that sits behind the maxilla. We're going to think of the pterygopalatine fossa as a house for sale and talk about its design, location, neighbors, and even the furnishings it comes with. First, let's talk about the shape of the house. The pterygopalatine fossa is shaped like an upside-down trapezoidal prism, and it is situated in a prime location, just posterior to the maxilla. So right off the bat, it makes sense that it's bounded anteriorly by the posterior aspect of the maxilla. Posteriorly, it's bounded by the pterygoid process of the sphenoid. Medially, the fossa is bounded by the perpendicular plate of the palatine bone, whereas laterally it opens into the pterygomaxillary fissure. Its roof is formed by the infratemporal surface of the greater wing of the sphenoid bone, and it is incomplete as there is an opening into the inferior orbital fissure. Finally, the floor is formed by the pyramidal process of the palatine bone with an opening into the palatine canal. This means the pterygopalatine fossa's neighbors include the middle cranial fossa, infratemporal fossa, orbit, nasal cavity, the roof of the oral cavity, and maxillary sinus, and the pharyngeal vault. Now, the pterygopalatine fossa communicates with its neighbors, aka surrounding structures, through many openings. First, it communicates with the middle cranial fossa through the foramen rotundum, located anteromedially on the sphenoid bone. The foramen rotundum provides passage for the maxillary nerve, which is the second main division of cranial nerve 5. Another connection to the middle cranial fossa is through the pterygoid canal within the sphenoid bone. The canal provides passage for the nerve and artery of the pterygoid canal. The pterygopalatine fossa communicates with the infratemporal fossa through the pterygomaxillary fissure, which transmits the posterior superior alveolar nerve and artery and the maxillary artery. It communicates with the nasal cavity through the sphenopalatine foramen, which transmits the sphenopalatine artery and vein and the nasopalatine nerve. Fifth, it communicates with the orbit through the inferior orbital fissure, which provides passage for the zygomatic branch of the maxillary nerve and the infraorbital nerve, artery, and vein. Next, it communicates with the pharynx via the palatovaginal canal, which transmits the pharyngeal nerve and artery. Lastly, the pterygopalatine fossa communicates with the mucosa of the hard and soft palate via the palatine canal. Before we move on, can you recall the boundaries of the pterygopalatine fossa? Now, this house also comes fully furnished. Some of the most important structures you can find within the fossa include the terminal part of the maxillary artery and the proximal parts of its branches, their accompanying veins, the maxillary nerve, and the pterygopalatine ganglion. First, the maxillary artery is one of the terminal branches of the external carotid artery. From its origin posterior to the lateral pterygoid muscle, it passes anteriorly through the infratemporal fossa and eventually makes its way to the pterygomaxillary fissure. Then, it enters the pterygopalatine fossa and eventually terminates as the sphenopalatine artery. The maxillary artery gives off branches along its trajectory which usually accompany the nerves entering and exiting the fossa. First is the descending palatine artery, which passes through the palatine canal and divides into the greater palatine artery and lesser palatine artery to supply most of the soft palate and hard palate. Next is the posterior superior alveolar artery, which exits the fossa through the pterygomaxillary fissure and then enters the alveolar foramen of the maxilla to supply the maxillary sinus and the upper premolar and molar teeth and their gingivae. There's also the pharyngeal artery, which supplies the roof of the nasal cavity and the sphenoidal sinus, and the artery of the pterygoid canal, which supplies the tympanic cavity. Both branches also supply the pharynx and pharyngotympanic tube. Next is the infraorbital artery, which enters the inferior orbital fissure, travels through the infraorbital canal, and exits the skull through the infraorbital foramen. It supplies the inferior oblique and inferior rectus muscles, lacrimal sac, maxillary canines and incisors, the mucosa of the maxillary sinus, and the overlying skin. Finally, the sphenopalatine artery exits the pterygopalatine fossa through the sphenopalatine foramen. From here, it enters the nasal cavity, where it gives rise to lateral nasal and septal branches that supply its lateral and medial walls. Next up, there's the maxillary nerve. It originates in the middle cranial fossa and runs anteriorly through the foramen rotundum to enter the posterior wall of the pterygopalatine fossa. The maxillary nerve gives off 8 branches. The first one is the zygomatic nerve, which enters the orbit through the inferior orbital fissure and gives off the zygomaticofacial nerve and zygomaticotemporal nerve. The zygomaticofacial nerve leaves the orbit and emerges on the anterolateral aspect of the zygomatic bone, supplying the overlying skin. The zygomaticotemporal nerve leaves the orbit and enters the temporal fossa to supply the skin over the temple. Next is the posterior superior alveolar nerve, which travels with its arterial counterpart to supply the maxillary sinus, the molar teeth, and their adjacent gingivae. Next up, the infraorbital nerve, which follows the infraorbital artery to supply the mucosa of the maxillary sinus, premolar, canine, and incisors maxillary teeth, skin and conjunctiva of the inferior eyelid, lateral nose and antero-inferior septum, and the skin and mucosa of the upper lip. The next branch is the nasopalatine nerve, which travels through the sphenopalatine foramen to enter the nasal cavity. It runs across the nasal septum to the incisive canal, where it then enters the roof of the oral cavity. It supplies the nasal septum and the anterior part of the oral mucosa of the hard palate. Next is the pharyngeal nerve, which passes posteriorly to supply the mucosa of the nasopharynx. Finally, the greater palatine nerve and lesser palatine nerve follow their associated arteries. The greater palatine nerve supplies most of the gingivae and mucous membrane of the hard palate, whereas the lesser palatine nerve supplies the soft palate. Okay, finally, let's talk about the nerve of the pterygoid canal and the pterygopalatine ganglion. The nerve of the pterygoid canal forms in the middle cranial fossa by the joining of the greater petrosal nerve, a branch from the facial nerve, and the deep petrosal nerve, a branch from the internal carotid plexus. The greater petrosal nerve branches from the facial nerve at the geniculate ganglion and carries preganglionic parasympathetic fibers. Postganglionic sympathetic fibers from the superior cervical sympathetic ganglion in the neck form the internal carotid plexus. In the middle cranial fossa, some fibers leave the plexus as the deep petrosal nerve and join with the greater petrosal nerve to form the nerve of the pterygoid canal, which exits through the foramen lacerum to enter the pterygopalatine fossa. Once it enters the fossa, it passes through the pterygopalatine ganglion, where only the parasympathetic fibers from the greater petrosal nerve synapse. The sympathetic fibers from the deep petrosal nerve fibers do not synapse in the ganglion, but instead pass directly through. Both the parasympathetic and sympathetic fibers leave the ganglion with branches of the maxillary nerve, on which they hitchhike to their targets. Before the recap, can you recall the main branches of the maxillary nerve in the pterygopalatine fossa? Alright, as a quick recap, the pterygopalatine fossa is bounded anteriorly by the maxilla and posteriorly by the pterygoid process of the sphenoid, medially by the perpendicular plate of the palatine bone, and laterally by the pterygomaxillary fissure. The roof is formed by the infratemporal surface of the greater wing of the sphenoid and the floor by the pyramidal process of the palatine bone. The fossa communicates with the middle cranial fossa through the foramen rotundum and the pterygoid canal, the infratemporal fossa through the pterygomaxillary fissure, the nasal cavity through the sphenopalatine foramen, the pharynx through the palato-vaginal canal, the orbit through the inferior orbital fissure, and the palate through the palatine canal. The fossa contains the terminal portion of the maxillary artery, the maxillary nerve, and the pterygopalatine ganglion, which receives preganglionic parasympathetic fibers via the greater petrosal nerve and postganglionic sympathetic fibers via the deep petrosal nerve. Only the parasympathetic fibers synapse in the ganglion, and both the parasympathetic and sympathetic fibers leave the ganglion with branches of the maxillary nerve.
Have you ever smelled something so good that your mouth begins to water? Well, you can thank your salivary glands for this mouth-watering sensation. The salivary glands, while often overlooked, are a key part of our digestive system. There are three main pairs of salivary glands: the parotid, submandibular, and sublingual glands. There are also a few smaller companions called accessory salivary glands, which are sprinkled over the palate, lips, cheeks, tonsils, and tongue. When it comes to function, salivary glands secrete saliva into the oral cavity. Saliva, as you may know, is a clear, tasteless, and odorless fluid that keeps the mouth's mucosa hydrated. Saliva also helps lubricate food while we chew, making swallowing easier. And it also starts the digestion of starch because it contains an enzyme called amylase. Saliva also acts as nature's mouthwash, since it's rich in antimicrobial compounds such as hydrogen peroxide to keep our mouths clean. Accessory salivary glands have a similar role, except they tend to secrete less saliva. The parotid glands are the largest of the three paired salivary glands. Superficially, each parotid gland is triangular in shape, where it sits upon the masseter muscle. However, most of the parotid gland actually sits in the retromandibular fossa, antero-inferior to the external acoustic meatus, where it is wedged between the ramus of the mandible and the mastoid process and sternocleidomastoid muscle posteriorly. Its apex is situated posterior to, or along, the angle of the mandible, while the base is associated with the zygomatic arch. The parotid gland is surrounded by a protective sheath derived from the investing layer of the deep cervical fascia called the parotid sheath. Now, a number of structures are closely associated with the parotid gland. First, the extracranial portion of the facial nerve passes through the parotid gland and forms the parotid plexus. Although it is embedded within the gland, the parotid plexus does not innervate it on its way to the muscles of facial expression. It also encloses the retromandibular vein and the external carotid artery. The auriculotemporal nerve and the superficial temporal artery can also be found traversing the superior part of the parotid gland. Another important structure associated with the parotid gland is the parotid duct, which is how the saliva produced in the parotid gland gets transported to the oral cavity. The duct passes horizontally along the parotid gland, where it reaches the anterior border of the masseter and turns medially to pierce the buccinator muscle, entering the oral cavity opposite the second maxillary molar where it releases saliva. Now, regarding nerve supply, we've mentioned that the parotid plexus formed by the facial nerve doesn't innervate the parotid gland. Instead, sensory innervation is provided by a branch of the mandibular division of the trigeminal nerve called the auriculotemporal nerve, and the great auricular nerve, which is a branch of the cervical plexus. Like all glands, the parotid gland also needs parasympathetic and sympathetic innervation to ensure adequate saliva secretion. For the parotid gland, the stimulatory parasympathetic fibers are from the glossopharyngeal nerve. The glossopharyngeal nerve sends preganglionic fibers to the otic ganglion, which is located in the infratemporal fossa, just inferior to the foramen ovale, medial to the mandibular nerve, and posterior to the medial pterygoid muscle. From the otic ganglion, the postganglionic parasympathetic fibers reach the parotid gland by hitching a ride along the fibers of the auriculotemporal nerve. Sympathetic fibers are supplied by the superior cervical ganglion via the external carotid plexus, whose fibers travel along the external carotid artery to reach the parotid gland. Parasympathetic innervation stimulates saliva production, while sympathetic stimulation will reduce production. Time for a quick break. Can you recall the structures that pass through the parotid gland? Now let's look at the submandibular glands, which are located near the posterior half of the mandible in the submandibular triangle. Each submandibular gland has a superficial and a deep lobe. The superficial lobe lies inferior to the body of the mandible and superficial to the mylohyoid muscle, while the deep lobe lies deep to the mandible and the mylohyoid muscle. The facial artery passes deep to the submandibular gland, while the facial vein passes superficial to it. The deep lobe of the submandibular gland contacts the parotid gland posteriorly. The submandibular gland also comes with its very own submandibular duct, which is located on the medial side of the gland. The duct starts where the gland lies between the mylohyoid and hyoglossus muscles, and then it passes from lateral to medial to meet the lingual nerve, which loops under the duct. The duct then opens at the sublingual caruncle, on either side of the base of the frenulum of the tongue. Check out the openings of these ducts yourself by lifting up your tongue while looking in the mirror. Finally, let's look at the sublingual glands, which are the smallest of the three pairs. Each sublingual gland is almond-shaped and lies on the floor of the oral cavity, between the mandible and the genioglossus muscle. But this gland doesn't like a solitary life, so it unifies anteriorly with its twin from the other side of the mouth to form a horseshoe-shaped body around the connective base of the frenulum. Its unified body has numerous sublingual ducts or ductules, which open directly into the floor of the mouth. The sublingual glands are closely associated with the submandibular ducts and the lingual nerves, which meet the sublingual glands medially. Now, what about the innervation of these glands? Well, both the submandibular and the sublingual glands receive parasympathetic and sympathetic innervation from the same nerves. Preganglionic parasympathetic fibers come from the chorda tympani nerve, which is a branch of the facial nerve. The chorda tympani will then hitch a ride with the lingual nerve, which is a branch of the mandibular nerve, to head towards the submandibular ganglion. Here, the fiber synapse with postganglionic neurons in the submandibular ganglion, which lies near the third mandibular molar hanging just below the lingual nerve. From the submandibular ganglion, some fibers continue to be carried to the glands by the lingual nerve, while others travel directly to the glands. Sympathetic fibers are provided by the superior cervical ganglion, which travel through the external carotid plexus and other periarterial plexuses to these glands. Alright, as a quick recap, The parotid gland is located in the retromandibular fossa and along the masseter muscle. Within the parotid gland, you can find the parotid plexus of the facial nerve and its branches, the retromandibular vein, and the external carotid artery. The parotid gland secretes saliva through the parotid duct, which opens in the oral cavity opposite the second maxillary molar. Parotid parasympathetic fibers are from the glossopharyngeal nerve, which synapse in the otic ganglion before traveling via the auriculotemporal nerve to the parotid gland, and sympathetic fibers are supplied via the external carotid plexus. The submandibular gland has a superficial and a deep lobe that lies along either side of the mylohyoid muscle. It secretes saliva through the submandibular duct, which opens in the oral cavity through the sublingual caruncle. Finally, the sublingual glands sit on the floor of the oral cavity where numerous ductules open directly into the mouth's floor. Both the submandibular and the sublingual gland receive parasympathetic fibers from the chorda tympani nerve, which joins and travels along the lingual nerve. Its fibers then synapse in the submandibular ganglion before continuing to reach the glands. Sympathetic fibers are also supplied via the external carotid plexus. Getting into medical school must have been a jaw-dropping moment, but have you ever wondered how it is that your jaw didn't fall off? You can thank the temporomandibular joint for that. Now, the temporomandibular joint is a modified synovial hinge joint. So first, just like a hinge joint, it allows for flexion and extension, which translate to elevation and depression of the jaw, respectively. Additionally, the TMJ also allows for gliding and rotation. The articular components of this joint include the mandibular fossa and the articular tubercle of the temporal bone as the superior surface, and the head of the mandible as the inferior surface. Unlike your average hinge joint, the articular surfaces don't make direct contact here. They're separated by an articular disc, which is attached to the inner surface of the joint's fibrous capsule. The articular disc divides the joint into two parts: the superior articular cavity, which allows the mandible to glide, causing protrusion and retrusion, and the inferior articular cavity, which allows the hinge movements, elevation or closing of the jaw, and depression or opening of the jaw, as well as rotational movements. With all of these movements at the temporomandibular joint, there needs to be strong surrounding support so it doesn't become dislocated. This is where ligaments come in handy. The temporomandibular joint is enveloped by the joint capsule and strengthened by 1 intrinsic and 2 extrinsic ligaments. The intrinsic ligament, called the lateral ligament, is a thickening of the joint capsule and extends from the articular tubercle to the neck of the mandible. It strengthens the joint laterally and helps prevent posterior dislocation. The 2 extrinsic ligaments are the sphenomandibular ligament and the stylomandibular ligament. The sphenomandibular ligament extends from the spine of the sphenoid bone to the lingula of the mandible. It supports the joint and serves as a prop during hinge movements. The stylomandibular ligament extends from the styloid process of the temporal bone to the angle of the mandible. It strengthens the joint, but not as much as other ligaments. Now, the joint can't move on its own. It needs muscles, specifically the muscles of mastication, which are all innervated by branches of the mandibular division of the trigeminal nerve, also known as the mandibular nerve. First up, there's the temporalis muscle. It originates from the temporal fossa and the deep surface of the temporal fascia. The temporalis inserts on the coronoid process of the mandible and the anterior border of the ramus of the mandible. It is innervated by deep temporal nerves. The temporalis elevates the mandible, and its posterior fibers, which are more horizontal, retrude the mandible. The next muscle is called the masseter, and it's a strong muscle that originates on the zygomatic arch and the maxillary process of the zygomatic bone. It inserts on the angle and the lateral surface of the ramus of the mandible. The masseter mainly elevates the mandible, but superficial fibers contribute to protrusion, and it's innervated by the masseteric nerve. The third muscle of mastication, called the medial pterygoid muscle, is made of 2 heads, the deep head and the superficial head. The deep head originates from the medial surface of the lateral pterygoid plate and the pyramidal process of the palatine bone. The superficial head originates from the tuberosity of the maxilla. Both heads insert on the medial surface of the ramus and angle of the mandible. The medial pterygoid muscle is innervated by the medial pterygoid nerve. Bilaterally, it acts very similar to the masseter, producing elevation and protrusion of the mandible. When alternate unilateral contraction occurs, it also produces small side-to-side grinding movements of the jaw. The last muscle of mastication is the lateral pterygoid muscle, which is also made of two heads. The superior head originates from the infratemporal surface and crest of the greater wing of the sphenoid bone and inserts directly on the joint capsule and the articular disc. The inferior head originates from the lateral surface of the lateral pterygoid plate and inserts on the pterygoid fovea on the neck of the mandible. This muscle is innervated by the lateral pterygoid nerve. Bilaterally, the lateral pterygoid muscle is involved in protrusion and depression of the mandible, while unilaterally it helps with lateral or side-to-side chewing movements. Let's take a quick break before we continue. Can you identify all muscles of mastication on this image? Now let's take a comprehensive look at how these muscles work together to produce various movements that occur at the TMJ. Hinge movements, which include elevation and depression, occur between the head of the mandible and the articular disc in the inferior articular cavity. Elevation involves the temporalis, the masseter, and the medial pterygoid muscle. The main force acting during depression is gravity, but it also involves the lateral pterygoid muscle. Now, to open the mouth completely, like when you're at the dentist, the mandible and the articular disc have to glide forward until the head of the mandible is under the articular tubercle. So, this movement involves both depression and protrusion. Gliding movements like protrusion and retrusion occur in the superior articular cavity as the head of the mandible and the articular disc move simultaneously against the mandibular fossa and the articular tubercle of the temporal bone. Protrusion involves the lateral pterygoid, medial pterygoid, and masseter muscles, while retrusion involves temporalis. Lastly, the mandible can also move laterally during chewing and grinding movements. During lateral movement, one side protrudes while the other side rotates slightly. This movement is carried out by the temporalis and the masseter on the side the mandible is moving toward, and the lateral and medial pterygoid muscles on the opposite side. Lastly, let's talk about the innervation of the temporomandibular joint. Hilton Law says that a joint is innervated by articular branches of nerves that innervate the muscles acting on the joint. So naturally, the temporomandibular joint is innervated by articular branches of the mandibular nerve, specifically branches of the auriculotemporal and masseteric nerves. Alright, as a quick recap, the temporomandibular joint is a modified synovial hinge joint between the mandibular fossa and the articular tubercle of the temporal bone superiorly, and the head of the mandible inferiorly. Articular components are separated by the articular disc, which divides the joint into the superior and inferior articular cavities. The temporomandibular joint is strengthened by one intrinsic ligament called the lateral ligament and two extrinsic ligaments, the stylomandibular ligament and the sphenomandibular ligament. The muscles of mastication are the temporalis, the masseter, the medial pterygoid, and the lateral pterygoid muscle. They are all innervated by branches of the mandibular nerve, deep temporal nerves, the masseteric nerve, the medial pterygoid nerve, and the lateral pterygoid nerve, respectively. The temporomandibular joint is innervated by articular branches of the mandibular nerve. The temporomandibular joint allows for hinge movements like elevation and depression, as well as gliding movements like protrusion and retrusion, and lateral or side-to-side movements used when grinding food.
The tongue is part of what makes these videos possible. Without it, we couldn't speak. It is also what allows us to enjoy the taste of our favorite foods and helps us get the occasional pesky bit of food out from between our teeth. Now, the tongue is essentially a mass of muscles covered by a mucous membrane, which can contract and relax quickly, allowing the tongue to assume many shapes and positions. This is what makes the tongue ideal for speaking by aiding sound formation. The tongue is also involved in taste via taste receptors. It pushes food to the oropharynx during swallowing. It helps with mastication by moving food closer to our teeth, and in oral cleansing. Looking at things in more detail, the tongue takes up much more space in the mouth than you might realize. It consists of a root, a body, and an apex, with the last two being highly mobile. The root of the tongue is posterior and slightly vertical, forming the posterior 1/3 of the tongue. It extends from the hyoid, epiglottis, and soft palate to the mandible. The body forms the anterior 2/3 of the tongue, and the apex of the tongue is the most anterior end of the body. The entirety of the tongue rests on the mouth's floor, both in the oral cavity and into the oropharynx, with the apex pressing against the lower incisors. The tongue also has two surfaces, superoposterior and inferior, which are separated by the margin of the tongue. The superoposterior surface is the larger of the two, and it literally represents the top or dorsum of the tongue. The inferior surface or underside rests against the floor of the mouth. The dorsum of the tongue is characterized by a V-shaped groove called the terminal sulcus. The sulcus divides the top of the tongue transversely into a presulcal anterior part in the oral cavity and a postsulcal posterior part situated in the oropharynx. The V's tip points posteriorly to something called the foramen cecum, which represents the remnant of part of the embryonic thyroglossal duct, from which the thyroid gland developed. The dorsum also presents a central groove called the median lingual sulcus, which separates the anterior part of the tongue into a right and left division. This area is sprinkled with numerous different types of lingual papillae. There are 4 main types of lingual papillae, including valate, foliate, filiform, and fungiform papilla, which give the tongue its rough texture. All of these papillae contain taste buds, with the exception of the filiform papillae. First off, there are large and flat valate papillae, which are arranged in a V-shaped row directly anterior to the terminal sulcus. The papillae are surrounded by circular trenches, whose walls contain the actual taste buds. Second, foliate papillae are poorly developed lateral folds of lingual mucosa, which are more developed in animals than humans. They are located posteriorly, lateral to the terminal sulcus. Next, filiform papillae are scaly, conical projections covering most of the anterior 2/3 of the tongue. Filiform papillae do not contain taste buds, but they contain touch-sensitive nerve endings, and they help with scraping movements that allow soft foods, like ice cream, to enter your mouth. Fun fact, in cats, these papillae are much more developed, which helps them with grooming. Lastly, fungiform papillae are mushroom-shaped structures located amongst the filiform papillae, especially at the apex and margins of the tongue. The mucosa of the posterior part of the tongue, situated posterior to the terminal sulcus, is thick and contributes to the anterior wall of the oropharynx. It presents no lingual papillae, but it's scattered with lymphoid nodules, which give it a cobblestone appearance. These nodes are collectively known as the lingual tonsils, and they are involved in the immune response to oral pathogens. Now, the inferior surface of the tongue, or its underside, is the smooth surface that rests against the mouth's floor. It is smooth because it is covered in a thin, transparent mucous membrane, which is connected to the floor of the mouth by a fold of tissue called the frenulum. The frenulum allows free movement to the anterior part of the tongue, while also helping to anchor the tongue within the mouth. On each side of the frenulum, you can actually see a deep lingual vein and a sublingual caruncle, which is a small swelling of tissue. The sublingual caruncles on each side contain the openings of the submandibular ducts, through which the submandibular salivary glands empty their contents into the oral cavity. Try looking for these structures on yourself by looking in a mirror and lifting up your tongue. Next, let's talk about the muscles that make up our tongue. These can be divided into extrinsic and intrinsic muscles, which act independently or together to alter the position and shape of the tongue. The 4 intrinsic and 4 extrinsic muscles in each half of the tongue are separated by the median lingual septum. In general, the extrinsic muscles alter the position of the tongue, while the intrinsic muscles alter its shape. Let's begin with the extrinsic muscles of the tongue, which include the genioglossus, hyoglossus, styloglossus, and paladoglossus. Their role is mainly in moving the tongue, but they can help alter its shape as well. First, the genioglossus is an anterior fan-shaped muscle that accounts for most of the tongue muscle. It originates on the mental spine of the mandible and inserts on the dorsum of the tongue and the body of the hyoid bone. Its main actions include tongue depression, protrusion, and contralateral deviation. Bilaterally, the genioglossus muscles create a longitudinal furrow that helps during swallowing. The hyoglossus sits posterior to the genioglossus, and it originates on the body and greater horn of the hyoid bone. It then goes on to insert on the inferolateral part of the tongue. Its main role is in tongue depression and retrusion. Next is the styloglossus, and as its name suggests, it originates on the distal styloid process and stylohyoid ligament. It then inserts on the posterior sides of the tongue between the fibers of the hyoglossus muscle. It helps retrude and curl or elevate the sides of the tongue, which works with genioglossus during swallowing. And finally, the paladoglossus originates on the palatine aponeurosis of the soft palate and inserts on the posterolateral aspect of the tongue, blending with fibers from the intrinsic tongue muscles. Its role is in elevating the posterior tongue and depressing the soft palate. Now let's talk about the intrinsic muscles of the tongue, which include the superior and inferior longitudinal, transverse, and vertical muscles. They have their attachments entirely within the tongue and are not attached to any bone. First, the superior longitudinal muscle is involved in shortening and curling the apex and sides of the tongue upward, while the inferior longitudinal muscle shortens and curls the apex and sides back downward. Next, the transverse muscle's main role is in narrowing and elongation of the tongue, while the vertical muscle has the opposite effect to its transverse brother, as it flattens and broadens the tongue. These two muscles work together to help protrude the tongue as well. Time for a quick break. Can you recall the 4 extrinsic and the 4 intrinsic muscles of the tongue? Now let's talk about innervation. Okay, so all muscles of the tongue except the paladoglossus, which is supplied by the pharyngeal plexus, receive motor innervation from the 12th cranial nerve, called the hypoglossal nerve. After exiting the hypoglossal canal, the hypoglossal nerve heads downwards towards the inferior angle of the mandible, crossing the internal and external carotid arteries laterally, and it sits medial to the posterior belly of the digastric muscle. It then reaches the submandibular triangle, where it lies medial to the submandibular gland and courses anteriorly on the lateral aspect of the hyoglossus muscle and deep to the mylohyoid muscle. Finally, it reaches the tongue, where it provides motor branches to the intrinsic and extrinsic muscles of the tongue. When it comes to sensory innervation, the mucosa of the anterior 2/3 of the tongue is supplied by different nerves. For example, general sensation is supplied by the lingual nerve, a branch of the mandibular division of the trigeminal nerve. The lingual nerve originates in the infratemporal fossa and descends anteriorly on the medial aspect of the mandible. The lingual nerve then passes from lateral to medial, looping under the submandibular duct, where it finally enters the lateral margin of the tongue to supply general sensation to its anterior 2/3. Special sensory or taste sensation of the anterior 2/3 of the tongue is relayed to the brain via the chorda tympani nerve, a branch of the 7th cranial nerve, the facial nerve. The chorda tympani also exits the skull into the infratemporal fossa, where it merges to hitch a ride with the lingual nerve to get to the anterior 2/3 of the tongue, which allows the special afferent fibers to relay special sensation back to the brain, making sure we all have impeccable taste. Now you may be thinking, what about the posterior third of the tongue? Well, general and special taste sensation to the mucosa of the posterior third of the tongue and the valate papilla are relayed to the brain via the 9th cranial nerve, the glossopharyngeal nerve. This nerve enters the pharynx between the superior and middle pharyngeal constrictor muscles, where it divides into branches to the palatine tonsils, the posterior wall of the pharynx, and the tongue. By contrast, a small area of the tongue just anterior to the epiglottis is supplied mainly for general, but also some special sensation via the internal laryngeal nerve, a branch of the vagus nerve. Finally, it is also important to note that we have 5 basic taste sensations: sweet, salty, sour, bitter, and umami, with the tongue having areas that are more sensitive to some of these sensations than others. Although all areas of the tongue are capable of detecting each of these 5 tastes, different areas detect these tastes at different intensities. For example, sweetness is mainly detected at the apex, saltiness at the lateral margins, sourness more posteriorly at the lateral margins, bitter at the posterior aspect around the terminal sulcus, and lastly, umami at the central part of the tongue. Time for a quick quiz. Can you recall the general and special sensory innervation of the anterior 2/3 of the tongue? What about the general sensory and special sensory innervation of the posterior third of the tongue? Now, let's talk about blood supply of the tongue, which is mainly provided by the lingual arteries. The lingual arteries are anterior branches of the external carotid arteries, arising on the middle pharyngeal constrictor from where they move towards the hyoid bone. Upon entering the tongue, the lingual arteries pass deep to the hyoglossus muscles and branch to supply the entire tongue. Venous blood is drained via the lingual veins and their tributaries. Finally, lymph from the tongue drains to the superior and inferior deep cervical lymph nodes, as well as the submandibular and submental lymph nodes. All right, as a quick recap, the tongue has 3 main parts: a root, a body, and an apex, and 2 surfaces, the inferior surface and the supero-posterior surface, also known as the dorsum of the tongue. The 4 types of lingual papillae are found on the dorsum of the tongue and include the valate, foliate, filiform, and fungiform papilla. The mucosa of the posterior third of the tongue is scattered with lymphoid nodules, together known as the lingual tonsils. The 4 extrinsic muscles of the tongue are the genioglossus, hyoglossus, styloglossus, and paladoglossus. Their role is mainly in moving the tongue, but they can help alter its shape as well. The intrinsic muscles of the tongue include the superior and inferior longitudinal, transverse, and vertical muscles, and they mainly help control the shape of the tongue. All muscles of the tongue except the paladoglossus receive motor innervation from the hypoglossal nerve. General sensation to the anterior 2/3 of the tongue is supplied by the lingual nerve, while special taste sensation is supplied by the chorda tympani nerve. The posterior third of the tongue gets general and special taste sensation mainly from the glossopharyngeal nerve. Blood supply to the tongue is mostly through the lingual arteries, while venous blood is drained via the lingual veins. Lymph from the tongue drains to the superior and inferior deep cervical lymph nodes, as well as the submandibular and submental lymph nodes.
The cranium, or skull, is the bony structure that protects the structures found inside our head, and it's divided into 2 parts, the viscerocranium and the neurocranium. Viscera refers to the organs within the body cavities, so viscerocranium is the lower and anterior part of the skull that forms the orbits, the nasal cavities, and the oral cavities. In other words, the facial skeleton. Neuro, on the other hand, refers to the nervous system, so the neurocranium, also called the cranial cavity, is the superior and posterior part of the skull that houses the brain and its membranous coverings, the cranial meninges, and also blood vessels and the proximal parts of the cranial nerves. Let's look at the viscerocranium first, which is actually made up of 15 bones. Only 3 of them are unpaired bones, and they sit on the midline: the mandible, ethmoid, and vomer. Then there are 6 pairs of paired symmetrical bones: the maxilla, the inferior nasal concha, as well as the zygomatic, palatine, nasal, and lacrimal bones. Most of these bones articulate with each other by fibrous or immovable joints, except for the mandible, which articulates only with the temporal bones by a synovial or movable joint. Next, the neurocranium is made up of 8 bones: the frontal, ethmoid, sphenoid, and occipital bones, which are singular and placed in the midline, then 2 temporal and 2 parietal bones, which are bilaterally paired. All these bones articulate by fibrous joints. In addition, the neurocranium can be further divided into the calvaria, or skull cap, and the cranial base, which would be like the roof and the floor of the neurocranium, respectively. The cranial base is where the foramen magnum is found, where the spinal cord is continuous with the brain. Alright, so let's get started with the bones of the viscerocranium. If you get face to face with a skull, you'll see the most bones of the viscerocranium. The maxillary bones occupy most of the surface. On each side there are the zygomatic bones, which form the skeleton of the cheek. Medial to the superior part of the maxillary bones, there are the nasal bones, and laterally there are the lacrimal bones. Now, if you look inside the piriform aperture, which is the opening to the nasal cavity, you can see the nasal septum formed by the ethmoid bone superiorly and the vomer inferiorly. You can also see the middle nasal conchae, which are also part of the ethmoid bone, and the inferior nasal conchae, which are their own separate bones. The most inferior bone of the face is the mandible. The only bones you won't see from this view are the palatine bones, which are behind the maxillary bones. Let's begin with the maxillary bones. These are two big irregular bones placed in the middle part of the face that form the upper jaw and help form the boundaries of the orbits, the nasal cavity, and the mouth. They articulate with one another on the midline, at the intermaxillary suture. The inferior border of each bone is called the alveolar process. That consists of a number of cavities, or alveoli, for the upper or maxillary teeth. The anterior border of both bones together form the piriform or nasal aperture. The superior border helps form the lower orbital margin, and the posterior border articulates with the sphenoid to help form the infratemporal fossa. Laterally, the maxilla articulates with the zygomatic bones, and anterior to this articulation, and inferior to each orbit, there's the infraorbital foramina, through which the infraorbital nerve and vessels pass. Superiorly and anteriorly, the maxilla frontal process articulates with the nasal, frontal, and lacrimal bones. Moving on to the zygomatic bones, these are two quadrilateral bones situated inferior and lateral to the orbits, so they're also called malar or cheekbones. In the center, they have a small opening called the zygomaticofacial foramen, through which the zygomaticofacial vessels and nerves pass in order to reach the cheeks, and make us blush when complimented. The zygomatic bones articulate with other bones of the facial skeleton through four processes: the frontal process, which articulates superiorly with the frontal bone, the orbital process, which articulates with the maxillary and sphenoid bone to form the floor of the orbit and also forms the lateral and inferior rims of the orbit, the maxillary process, which articulates inferiorly with the maxillary bone, and the temporal process, which articulates with the temporal bone to form the zygomatic arch and contributes the inferior boundary of the temporal fossa. Okay, now moving forward to the unpaired bones, let's take a look at the mandible. It's the bone that forms the lower jaw and results from the union of two bones in the midline at the mandibular symphysis. The mandible consists of two parts: the body, which is horizontal, and a vertical ramus on each side. The angle where each ramus joins the body is called the angle of the mandible, where part of the masseter muscle inserts. The body of the mandible presents the mental protuberance, which defines the shape of our chin. A bit lateral and posterior to the mental protuberance, there's the mental foramen, a hole through which the mental vessels and nerve pass. The superior border of the body is called the alveolar process that supports the mandibular teeth. The superior border of each ramus has a coronoid process anteriorly, which is thin and triangular, with the mandibular notch posterior to it. The mandibular notch is a concave depression that separates the coronoid process from the condyloid process posterior to it, which is thick and round-shaped, and articulates with the mandibular fossa of the temporal bone to form the temporomandibular joint. Okay, so before we move on, feel free to pause the video and see if you can label the bones on this frontal view of the skull. Alright, now let's switch gears and look at the bones of the neurocranium, starting with the frontal bone. The frontal bone forms the skeleton of the forehead and protects the frontal lobes of the brain. It's an unpaired, flat bone that has two parts: the squamous part, which is flat and vertically oriented, and the horizontally oriented orbital part, which forms the anterior floor of the cranial cavity and the roof of the orbits. An external view of the bone shows, right where these two portions of the frontal bone bind are the supraorbital margins, a ridge above the orbit on each side. In the medial part of each one, the supraorbital nerve and vessels pass through the supraorbital foramen or notch. Now, seen from the inside of the cranial cavity, the squamous part of the frontal bone presents impressions on its surface that correspond to the frontal lobes. And in the midline, there's the sagittal sinus that ends on the frontal crest. The frontal crest provides attachment to the falx cerebri. Now, the frontal bone articulates to a number of bones. Inferiorly, in the middle part of the frontal bone is an area called the glabella, and below this is where the frontal bone articulates with the nasal, maxillary, and lacrimal bones. On the lateral end of the supraorbital margins, there are the zygomatic processes, which articulate with the zygomatic bones on each side. In the middle, the orbital part articulates with the ethmoid bone. The ethmoid bone is unpaired and found in the midline. It forms part of the nasal septum, the lateral walls and roof of the nasal cavities, the medial wall of the orbits, and the anterior cranial fossa. Next, let's look at the temporal bones. These bones are highly irregular bilateral bones on each side of the cranium, corresponding to where the ears are located. Each temporal bone consists of a squamous, tympanic, mastoid, and petrous part. The squamous part is flat, and it has a smooth, convex external surface where the temporalis muscle attaches. From the lower portion of the squamous part, the zygomatic process arises, and it articulates with the temporal process of the zygomatic bone, forming the zygomatic arch. The squamous part also has a depression called the mandibular fossa to articulate with the mandible. Right behind this articular surface, there's the tympanic part, which forms most of the external acoustic meatus and provides an attachment surface for the tympanic membrane. The mastoid part of the temporal bone is the most posterior part and gives attachment points to the occipitalis muscle and the posterior auricular muscle. The mastoid part has the mastoid process, which is posterior to the external acoustic meatus and lateral to the styloid process, which belongs to the petrous part. The mastoid process and the styloid process serve as attachment points for muscles and ligaments. From an internal and superior view of the temporal bone, we can see an opening on the petrous part, which is called the internal acoustic meatus. We can also see how it articulates with the sphenoid bone anteriorly, the occipital bone posteriorly, and the parietal bone superiorly. Now that we've looked at each bone separately, let's take a look at how they interact to form the calvaria, or the skull cap, which is the roof of the neurocranium. It's formed by 4 bones: the squamous part of the frontal bone, both parietal bones, and the squamous part of the occipital bone. Seen from the outside, in other words, in a superior view, the calvaria is a smooth, convex surface, and the most relevant features here are the sutures between the bones that comprise it, which are all synarthrosis joints. Between the frontal and both parietal bones, there's the coronal suture. Between both parietal bones, there's the sagittal suture in the midline, and between both parietal bones and the occipital bone, there's the lambdoid suture, named after the Greek letter lambda, to which it is similar. Where the lambdoid suture meets the sagittal suture, this point is called the lambda. Then, where the sagittal suture meets the coronal suture, this point is called the bregma. These are very important spots because, in newborns, the sutures are not fused yet and the gaps are called the anterior and posterior fontanelles, which provide space for the brain to grow and develop properly. Posterior to the bregma, there is the vertex, which is the most superior part of the calvaria. Going even further posteriorly, where the calvaria meets the base of the cranium, we have the external occipital protuberance. Finally, on a lateral view of the skull cap, you can see the squamous or squamosal suture that connects the temporal and parietal bones. At the anterior end of this suture, the frontal, parietal, temporal, and sphenoid bones join to form a letter H. This is called the pterion. Now feel free to take a quick break and pause the video to test your knowledge. Can you label the missing parts on the following image? Alright, as a quick recap, the cranium is divided into two parts, the viscerocranium and the neurocranium. The viscerocranium is the lower and anterior part of the skull, made up of 15 bones that forms the facial skeleton. Only 3 of them are unpaired bones, and they sit on the midline, the mandible, ethmoid, and vomer. Then there are 6 pairs of paired, symmetrical bones, the maxilla, the inferior nasal concha, as well as the zygomatic, palatine, nasal, and lacrimal bones. The neurocranium is the superior and posterior part of the skull, made up of 8 bones, the frontal, ethmoid, sphenoid, and occipital bones, which are singular and placed in the midline, then 2 temporal and 2 parietal bones, which are bilaterally paired. The calvaria, which is the roof of the neurocranium, is formed by 4 bones, the squamous part of the frontal bone, both parietal bones, and the squamous part of the occipital bone.
Humans make many different facial expressions, and they are an extremely important way that we communicate. They let people know when you are happy, like after getting a good mark on an anatomy test, or curious, like when you learn something new about the human body. Let's learn about the muscles responsible for our facial expressions. First, let's start with the scalp, which is a layer of skin and subcutaneous tissue that covers the cranium. It extends from the supraorbital margins on the frontal bone to the superior nuchal line on the occipital bone. Laterally, it covers the temporal fascia and extends to the zygomatic arches on each side. The scalp is made of 5 layers, which can be remembered easily as the first letter of each spells out the word scalp. Going in the order from superficial to deep, S stands for skin, C stands for connective tissue, A stands for aponeurosis or epicranial aponeurosis, L stands for loose connective tissue, and P stands for pericranium, which is the periosteum on the external surface of the cranium. The first 3 layers, skin, connective tissue, and the aponeurosis, are connected tightly together, forming a single unit called the scalp proper. Muscles of facial expression, simply known as the facial muscles, are found deep in the skin of the scalp, face, and neck. Most facial muscles are attached to bones or fascia on one end, and skin on the other, so that when they contract, they create facial expressions. All facial muscles originate from the mesoderm of the second pharyngeal arch, along with the facial nerve. During embryological development, a muscular sheet forms and begins to spread over the scalp, face, and neck, which later forms the facial muscles. This spreading carries the branches of the nerve of the second arch with it, which is the facial nerve, or cranial nerve 7. So all facial muscles are innervated by the branches of the facial nerve, which are the posterior auricular, temporal, zygomatic, buccal, marginal mandibular, and cervical nerves. A way to remember these last 5 branches that emerge from the parotid gland is by using the mnemonic "to Zanzibar by motor car." Now, let's look at each of the facial muscles. First up, the occipitofrontalis muscle, which has 2 bellies. The 2 bellies are connected by the epicranial aponeurosis, which is the aponeurosis that makes the 3rd layer of the scalp. The frontal belly originates on the epicranial aponeurosis and inserts on the skin superior to the eyes and nose. It is innervated by the temporal nerve. The occipital belly originates on the superior nuchal line of the occipital bone and inserts on the epicranial aponeurosis. The occipital belly is innervated by the posterior auricular nerve. Now, when the frontal belly contracts, it protracts the scalp, and when the occipital belly contracts, it draws the scalp back. When they work together, they elevate the eyebrows and wrinkle the forehead, making you look surprised. Next up is the orbicularis oculi muscle, which has two main parts, the palpebral part and the orbital part. The palpebral part is found mostly within the eyelid, and it originates on the medial palpebral ligament and inserts on the lateral palpebral ligament. The orbital part originates from the medial orbital margin and medial palpebral ligament and inserts on the skin around the orbit, forming a continuous ring that surrounds the orbital orifice. The superior part of the orbicularis oculi muscle is innervated by the temporal nerve, while the zygomatic nerve innervates the inferior part of the muscle. The function of the orbicularis oculi muscle is to close the eyelids. The palpebral part closes the eyelids gently, like when you blink or sleep, while the orbital part closes the eyelids tightly, like when you wink or squeeze the eyes shut. Okay, let's move on to the muscles of the eyebrows and the nose. The muscle of the eyebrows is called the corrugator supercilii, which sounds like a spell you'd learn at Hogwarts, but is actually a small muscle found deep in the eyebrows and is innervated by the temporal nerve. Corrugator supercilii originates on the medial part of the superciliary arch and extends laterally to insert onto the skin of the medial half of the eyebrow. When it contracts, the corrugator supercilii pulls the eyebrows medially and inferiorly, making vertical wrinkles at the root of the nose, which occurs when frowning. Now let's move on to the nose. There are three muscles of the nose: the procerus, nasalis, and the levator labii superioris aliquae nasi. All three muscles of the nose are innervated by the zygomatic nerve. The procerus originates on the nasal bone and the lateral nasal cartilage and inserts onto the skin in the lower part of the forehead, between the eyebrows. When it contracts, it depresses the medial ends of the eyebrows and creates transverse wrinkles on the dorsum of the nose. The largest muscle of the nose is the nasalis, which is made of two parts, a transverse part and an alar part. The transverse part originates on the maxilla on either side of the nose and extends towards the dorsum of the nose, meeting in the midline to insert on an aponeurosis. The alar part also originates on the maxilla, over the lateral incisor, and inserts on the alar cartilage. The transverse part narrows the nostrils, and the alar part expands or flares them. The levator labii superioris aliquae nasi originates on the frontal process of the maxilla and inserts on the upper lip and the alar cartilage of the nose. It flares the nostrils and raises the upper lip. Okay, now let's take a short break and try to remember which facial muscle closes the eyelids. Right, it's the orbicularis oculi muscle. Now let's tackle some muscles in the oral region. First up is the orbicularis oris muscle, which encircles the mouth. It originates on the maxilla, the mandible, and on the angle of the mouth, called the medialis. All of the fibers insert on the mucous membrane of the lips. The orbicularis oris muscle is innervated by the buccal nerve, and its function is to close the mouth by bringing the lips together. and protrudes the lips, like when kissing or whistling. So next time you are whistling a happy tune, remember it's the orbicularis oris that does the work. As for the muscles of the lips, we'll divide them into the muscles of the upper lip and the muscles of the lower lip. The muscles of the upper lip are the risorius, the levator anguli oris, the zygomaticus major, the zygomaticus minor, the levator labii superioris, and the levator labii superioris alaeque nasi, which we mentioned earlier. The risorius originates on the parotid fascia and the buccal skin, and it inserts on the medialis. The risorius retracts the corner of the mouth. The levator anguli oris originates on the infraorbital maxilla and also inserts on the medialis. It raises the corner of the mouth, like when grinning. The zygomaticus major originates on the zygomatic bone and inserts on the medialis. It elevates the corner of the mouth so we can smile. The zygomaticus minor originates on the zygomatic bone and inserts into the skin of the upper lip. The levator labii superioris originates on the infraorbital margin of the maxilla and also inserts into the skin of the upper lip. The zygomaticus minor, levator labii superioris, and the levator labii superioris alaeque nasi pull the upper lip upward. Of course, all muscles of the upper lip are also dilators of the mouth, and they're all innervated by the zygomatic and buccal nerves. Now, the muscles of the lower lip are the depressor anguli oris and the depressor labii inferioris. The depressor anguli oris originates on the base of the mandible and inserts on the medialis. It pulls the corner of the mouth downwards to express sadness. The depressor labii inferioris originates on the anterolateral body of the mandible and the platysma muscle. It inserts into the skin of the lower lip. It pulls the lower lip downward when you are sad or when you pout. Just like the muscles of the upper lip, both muscles of the lower lip are also dilators of the mouth. The marginal mandibular nerve innervates both the depressor anguli oris and the depressor labii inferioris. Okay, now let's discuss a muscle of the chin, called mentalis. The mentalis originates on the body of the mandible and inserts into the skin of the chin. It elevates and protrudes the lower lip, like when pouting, and is innervated by the marginal mandibular nerve. Lastly, we have a broad muscle of the neck called platysma. It originates on the suprascapular and the infraclavicular subcutaneous tissue. The platysma extends towards the mandible and inserts on the base of the mandible, blending with the facial muscles. The platysma is innervated by the cervical nerve. It depresses the mandible and draws the corners of the mouth downwards to grimace. It can also tense the skin of the lower face and neck to express stress. Since that was quite a bit of information, we can take a break here. Now, can you name all the muscles of the upper lip in this image? Before we wrap up, let's look at one final facial muscle called the buccinator. The buccinator is a rectangular muscle found deep in the cheek. It originates on the alveolar processes of the maxilla and the mandible, and the pterygomandibular raphe. Now, the pterygomandibular raphe, or the pterygomandibular ligament, is a thickening of the buccal pharyngeal fascia. The superior pharyngeal constrictor originates on the posterior side of the pterygomandibular raphe, while the buccinator originates on the anterior side. The buccinator extends anteriorly, where its fibers mingle with the fibers of the orbicularis oris muscle, and inserts on the medialis. The buccinator is innervated by the buccal nerve, and its main job is to press the cheek against the teeth, like when you're drinking from a straw. All right, as a quick recap, the scalp is a layer of skin and subcutaneous tissue that covers the cranium. It is made of 5 layers: skin, connective tissue, aponeurosis, loose connective tissue, and pericranium. All facial muscles originate from the mesoderm of the second pharyngeal arch, which is why they are all innervated by the branches of the facial nerve. The occipitofrontalis muscle has a frontal belly and an occipital belly, which are connected by the epicranial aponeurosis. Its function is to elevate the eyebrows and wrinkle the forehead. The orbicularis oculi muscle surrounds the orbit. Its palpebral part is found within the eyelid and is used to close the eyelids gently, and its orbital part is used to close the eyelids tightly. The muscle of the eyebrow is called corrugator supercilii, and it draws the eyebrows downward and medially, which occurs when frowning. The 3 muscles of the nose are the procerus, nasalis, and the levator labii superioris aliquae nasi. The nasalis and the levator labii superioris aliquae nasi are used to flare the nostrils. The orbicularis oris encircles the mouth, and its job is to close the mouth or protrude the lips. The muscles of the upper lip are the risorius, the levator anguli oris, the zygomaticus major, the zygomaticus minor, the levator labii superioris, and the levator labii superioris aliquae nasi. All muscles are involved in various lip movements. Muscles of the lower lip are the depressor anguli oris and the depressor labii inferioris. Both the muscles of the upper and lower lip are dilators of the mouth. The mentalis is a muscle of the chin and elevates and protrudes the lower lip. The platysma is found in the neck and depresses the mandible, draws the corner of the mouth downwards, and tenses the skin of the lower face and neck. Finally, the buccinator is a rectangular muscle found deep in the cheek and presses the cheeks against the teeth. The face contains an abundance of small muscles that work together to help us show our emotions. You can thank these muscles for everything your face does, from smiling and frowning to making funny faces in group pictures. Naturally, for those muscles to work, there are many tiny nerves, arteries, and veins that supply them. Let's start off with the sensory innervation of the face. Almost all of its sensory innervation is provided by the 5th cranial nerve, also known as the trigeminal nerve, which has 3 divisions. Its superior division is known as the ophthalmic nerve, and it provides sensory innervation for the part of the scalp anterior to the vertex of the head, the forehead, the upper eyelids, the dorsum of the nose, and the roof of the nasal cavity. The ophthalmic nerve arises from the trigeminal ganglion, leaves the skull through the superior orbital fissure, and enters the orbit, where it gives rise to 3 branches: the frontal nerve, the nasociliary nerve, and the lacrimal nerve. So let's look at them one by one. The frontal nerve runs across the roof of the orbit, and it gives rise to the supraorbital and the supratrochlear nerves. The supraorbital nerve exits the orbit through the supraorbital notch and supplies the skin of the anterior part of the scalp, the anterolateral forehead, and the middle of the upper eyelids. The supratrochlear nerve exits the orbit lateral to the trochlea and supplies the skin of the anteromedial forehead. Next is the nasociliary nerve, which divides into the anterior ethmoidal, the posterior ethmoidal, and the infratrochlear nerves. The anterior ethmoidal nerve travels a long way through the nasal cavity and exits between the nasal bone and the lateral nasal cartilage as the external nasal nerve. It supplies sensory innervation to the skin of the dorsum of the nose, the nasal ala, and the nasal vestibule. So whenever the tip of your nose feels itchy, you know it's that pesky external nasal nerve. The infratrochlear nerve is the terminal branch of the nasociliary nerve and exits the orbit on the medial angle. It innervates the medial part of the upper eyelid, the skin around it, and lateral to the root of the nose. The last branch of the ophthalmic nerve is the lacrimal nerve, which exits the orbit on the lateral angle and innervates the lateral side of the upper eyelid and the skin around it. The intermediate division of the trigeminal nerve is called the maxillary nerve and supplies the skin of the anterior part of the temporal region, the skin over the zygomatic bone, the lower eyelid, the cheek, the side of the nose, the nasal septum, and the upper lip. It travels anteriorly from the trigeminal ganglion, leaves the skull through the foramen rotundum in the sphenoid bone, and enters the pterygopalatine fossa. It then passes through the inferior orbital fissure to enter the orbit, where it gives off the zygomatic nerve. The maxillary nerve continues on and travels within the infraorbital groove and exits the orbit through the infraorbital foramen as the infraorbital nerve. It supplies sensory innervation to the skin of the lower eyelid, the side of the nose, part of the nasal septum, the cheek, and the upper lip. Now let's take a look at the zygomatic nerve, which travels to the lateral wall of the orbit. It gives rise to the zygomaticofacial nerve, which supplies the skin over the zygomatic bone, and the zygomaticotemporal nerve, which supplies the skin of the anterior part of the temporal region. Let's move to the inferior division of the trigeminal nerve, called the mandibular nerve. This nerve supplies the skin of the posterior part of the temporal region, the skin anterior to the auricle, the skin over the body of the mandible, and the skin of the lower lip and the chin. The mandibular nerve arises from the trigeminal ganglion and leaves the skull through the foramen ovale in the sphenoid bone. It gives rise to 3 branches that innervate the skin of the face: the auriculotemporal nerve, the buccal nerve, and the inferior alveolar nerve. The auriculotemporal nerve passes posterior to the mandible, deep to the parotid gland, and emerges posterior to the temporomandibular joint. It supplies the skin of the posterior part of the temporal region, the skin anterior to the auricle, and some parts of the external ear. The buccal nerve passes through the buccinator muscle and supplies the skin of the cheek. Finally, the inferior alveolar nerve passes through the mandibular foramen into the mandibular canal. Its terminal branch, called the mental nerve, exits the mandibular canal through the mental foramen and supplies the skin of the chin, the mandible, and the lower lip. Cervical spinal nerves also provide a small part of the sensory innervation to the face through the anterior and posterior rami of the C2 and C3 cervical spinal nerves. The great auricular nerve arises from the anterior rami of C2 and C3 spinal nerves and travels towards the face across the sternocleidomastoid muscle. It provides sensory innervation to the skin of the angle of the mandible and the inferior part of the ear. The lesser occipital nerve arises from the anterior ramus of the C2 spinal nerve and travels along the posterior border of the sternocleidomastoid muscle. It reaches the face posterior to the auricle and supplies the skin of the scalp posterior to the ear. The greater occipital nerve arises from the posterior ramus of the C2 spinal nerve and passes between the axis and the obliquus capitis inferior muscle. It pierces the trapezius muscle and emerges to supply the skin of the occipital part of the scalp. The last branch is the third occipital nerve, which arises from the posterior ramus of the C3 spinal nerve. It pierces the trapezius muscle and travels to the occipital region to supply the skin of the lower occipital and the suboccipital regions. Before we move on, let's take a short break. Can you recall what area of the face is innervated by the maxillary nerve? Now, motor innervation of the face is a bit more straightforward. All muscles of facial expression are innervated by the seventh cranial nerve, known as the facial nerve. The facial nerve exits the cranium through the stylomastoid foramen and provides a posterior auricular branch which innervates the auricularis posterior and occipital belly of the occipitofrontalis muscle. It then travels anteriorly and enters the parotid gland, where it forms the parotid plexus. This plexus gives rise to the temporal, the zygomatic, the buccal, the marginal mandibular, and the cervical branches of the facial nerve. Remember, to Zanzibar by motorcar. The temporal branch runs across the zygomatic arch and innervates the frontal belly of the occipitofrontalis, corrugator supercilii, and the superior part of the orbicularis oculi muscle. The zygomatic branch runs inferior to the eye and innervates the inferior part of the orbicularis oculi muscle and the muscles of the nose, procerus nasalis, and the levator labii superioris aliquae nasi. The buccal branch runs horizontally and innervates the muscles of the upper lip, mouth, and cheek, which are the risorius, levator angulioris, zygomaticus major, zygomaticus minor, levator labii superioris, orbicularis oris, and the buccinator. The marginal mandibular branch runs along the inferior border of the mandible and innervates the muscles of the lower lip and chin, the depressor anguli oris, depressor labii inferioris, and mentalis muscle. Lastly, the cervical branch travels posterior to the mandible and innervates the platysma. Now, let's move on to the arteries of the face and scalp. The majority of the blood supply to the face is provided by direct and indirect branches of the external carotid artery. Direct branches include the facial artery, the superficial temporal artery, the occipital artery, and the posterior auricular artery. The indirect branch of the external carotid artery is the mental artery. The rest of the face is supplied by two branches of the ophthalmic artery, which is a branch of the internal carotid artery, called the supraorbital and supratrochlear arteries. The facial artery runs through the neck, deep to the platysma, and appears at the inferior border of the mandible. It curves around the mandible, anterior to the masseter, and then runs across the face, lateral to the lips and nose. Then it travels deep into the risorius, zygomaticus major, and zygomaticus minor muscles to reach the medial angle of the eye, called the canthus, where it terminates as the angular artery. Along its path, the facial artery gives branches to the upper and the lower lips, called the superior and the inferior labial arteries. These branches travel superior and inferior to the mouth, and anastomose at the midline with the same arteries on the other side of the face. At the nose, the facial artery also gives rise to the lateral nasal artery, which supplies the lateral surface of the nose. The superficial temporal artery is one of two terminal branches of the external carotid artery. From the neck, the external carotid artery courses posterior to the ramus of the mandible and passes through the parotid gland, where it gives rise to the posterior auricular artery. After this final branch, it terminates as the superficial temporal artery, which courses between the temporomandibular joint and the ear, traveling upwards to supply the lateral scalp. The superficial temporal artery also gives rise to the transverse facial artery, which passes through the parotid gland to supply the lateral face. The occipital artery arises from the external carotid artery, superior to the facial artery, and travels posteriorly, reaching the occipital region to supply the scalp posterior to the vertex. The posterior auricular artery is a small branch of the external carotid artery that runs between the ear and the styloid process to supply the auricle and the scalp posterior to the ear. Now, the mental artery is an indirect branch from the external carotid artery. First, the external carotid artery gives off the maxillary artery, which then gives off the inferior alveolar artery. The inferior alveolar artery passes through the mental foramen of the mandible and emerges as the mental artery to supply the muscles and skin of the chin. Finally, let's look at the supraorbital and the supratrochlear arteries, which are the only two branches that do not arise from the external carotid artery. These branches are from the ophthalmic artery, which is a branch of the internal carotid artery. The supraorbital and the supratrochlear arteries follow the nerves of the same name and end in the forehead to supply the muscles and the skin of the forehead and the anterior scalp. Okay, that was quite a bit of information. Let's take a break here and review. Can you identify the arteries that supply the face on this image? Now let's move on to the veins of the face and the scalp. Blood is drained by superficial veins, which form many anastomoses with each other. Deeper veins, a dural venous sinus, and venous plexus. All facial veins are valveless, which allows blood to move in any direction, meaning if a vessel is compressed, blood can drain through a different path. Facial veins usually follow the arteries they are named after. The supratrochlear and the supraorbital veins merge at the root of the nose to form the angular vein, which descends to the inferior orbital margin and becomes a major vein of the face, called the facial vein. The facial vein follows the facial artery to the inferior border of the mandible and receives blood from smaller veins along the way. Posterior to the mandible, the superficial temporal and the maxillary veins merge into the retromandibular vein, which divides into an anterior and posterior branch. The anterior branch merges with the facial vein to form the common facial vein, which drains into the internal jugular vein. The posterior branch unites with the posterior auricular vein and forms the external jugular vein. Last but not least, let's discuss the lymphatic drainage of the face. Lymph from the face drains into the superficial ring of lymph nodes in the neck and lower face. The submental lymph nodes receive lymph from the central part of the lower lip and the chin. The submandibular lymph nodes receive lymph from the upper lip and lateral parts of the lower lip. Lymph from the lateral part of the face drains to the superficial parotid lymph nodes. Lymph from the nasal cavity drains into the deep parotid nodes. From the superficial lymph nodes, lymph runs to the deep cervical lymph nodes and then drains to the jugular lymphatic trunk, which joins the thoracic duct and flows into the internal jugular vein on the left side, or flows directly to the brachiocephalic vein on the right side. All right, as a quick recap, the trigeminal nerve provides almost all sensory innervation to the face through its three major branches: the ophthalmic nerve, the maxillary nerve, and the mandibular nerve. Branches of the ophthalmic nerve supply the sensory innervation for the part of the scalp anterior to the vertex, forehead, upper eyelids, and roof of the nose. Branches of the maxillary nerve supply the skin of the anterior part of the temporal region, skin over the zygomatic bone, lower eyelid, cheek, side of the nose, nasal septum, and upper lip. Branches of the mandibular nerve supply the skin of the posterior temporal region, skin anterior to the ear, skin over the body of the mandible, and skin of the lower lip and chin. A small part of the sensory innervation of the face comes from branches of the anterior and posterior rami of the C2 to C3 cervical spinal nerves. Motor innervation for the muscles of the face is provided by the facial nerve via its 6 branches: the posterior auricular, temporal, zygomatic, buccal, marginal mandibular, and cervical branch. The majority of the blood supply to the face is provided by the facial artery, superficial temporal artery, occipital artery, posterior auricular artery, or mental artery, which are direct or indirect branches of the external carotid artery. The supraorbital and the supratrochlear arteries arise as the terminal branches of the ophthalmic artery, which is a branch of the internal carotid artery. Blood from the face is drained by superficial veins, which follow the arteries they are named after. Lymph from the face drains into the superficial lymph nodes, which include the submental, the submandibular, and the parotid lymph nodes.